Well, this afternoon we are joined together, three comrades in arms over the past 25 to 45 years, in discussing some of the most important developments we feel in the field of public health. Central to what we are talking about are new concepts in applying public health immunization, in this case, to entire countries, entire populations. And they've had relevance well beyond just immunization and beyond health issues. We will be exchanging views on some of these events of the past, which have been central to Ciro de Quadros and his work from the time he came into being friends with us in 1969 up to the present. There have been many developments, signal developments for the whole of public health. And so it's a privilege to have the opportunity to talk today. On my right is John Andrus, who's known him since the past 24 years. I have known him for 44 years, both of us working in either as being his supervisor and others, one of us being one of his staff. But I think we all agree that what we've been doing is learning from each other as three colleagues. So to begin the discussion, I think it'd be helpful to have Ciro give us a bit of an orientation of where he came from in Brazil and how he got interested in public health and a bit of his early life, if you would, Ciro.
Thank you, dear, and it's really nice to share this afternoon with you and John, and this is really a privilege for me to go through memories of the past and look even at the future. I think the best years of my life was when I worked with all of you, and I think there is still much ahead, and I hope we will continue together. I'm from Brazil, as you mentioned. I come from a small town in Brazil called Rio Pardo in the south of the country. My family was from there, and when I was 14 years old, my parents sent me to the capital of the state, which is a town called Porto Alegre, to get better schooling. So I went and lived with my two brothers in a little pension where students used to live. We had a good time. And then I decided to go into medical school after I finished my years in the college. And I went into medical school, and was a school that was recently created at that time. When I was in the last year of the school is when you start deciding what do you want to do with your career. You know, I had made internships in cardiology. I had made internship in psychiatry. Actually worked in a psychiatric hospital for a while. But when I was in this last year of the school, I spent 2 months in a little village working in a hospital, replacing a doctor. At that time, I had a professor of nutrition, which was very good and motivated in terms of the needs of the population. We had the books of Freire, about and the other individuals that had written about the poverty in the Northeast and so on. And during these 2 months in this little hospital, I made a lot of money actually, and I could even go on vacation to Rio de Janeiro afterwards. But the lesson that I got from that experience was, really life-changing in a sense, because, I was treating the patients every day with diarrheal diseases, acute respiratory infections, and other ailments. You would treat them, they would go home, and a few days later they would come with the same thing. And then I realized that there was something else to be done in terms of, preventing those things to happen. And I think that's what really motivated me to go into public health. So with the money I got, I went to Rio de Janeiro on vacation, but I took the opportunity to go to the School of Public Health and ask if I could go to the school to do a master in public health. And I had a meeting with 3 professors, which were really also very important in my life, because they advised me not to go to the school. You see, they said, look, don't come here. First go to the field and work and see what are the problems, because when you come here, the teachers will tell you things and you don't know if they are true or not. And I think that was a very important advice. And I said, okay, so where should I go? And then they had experience with a service in Brazil called, at that time, Special Service of Public Health, which was an organization created by the Rockefeller Foundation during the, the war effort for the cleaning malaria in the Amazon, for the rubber extraction. And by that time, the Rockefeller had left, but the government had transformed that into a foundation, which was called the Special Service of Public Health Foundation, financed by the government. And that was the best experience I ever had in my life. That was, for me, what formed me as a public health worker, because, the clinic had, this was a town called Altamira in the middle of the Amazon. At that time, there was only one plane coming every Saturday, bringing the mail and supplies and so on. So the whole town would stop for the arrival of the plane, and every commerce would close, everything would go to get mail and see who was coming, And, but there was an organization in this foundation that you had quantifiable objectives to achieve in your village, in your town, in terms of vaccination, in terms of finding leprosy cases, finding TB cases, connecting houses to the water supply, and building latrines.
How many of you were there?
So
were you there alone? Or
I was the doctor. I had a nurse, a community nurse, had a lab technician, had a guy that was taking care of, of the administration, the management, the drugs, the arrival, whatever. And I had a sanitarian, which was a guy that was involved with all the water and, latrines and so on. Because the foundation had built a water supply place and had put the pipes through the streets of the village. But then we had to convince the owners of the house to connect to the house. And this was the work of this guy. And so this was the team in there. And that's when, I really learned how to do public health. And every 3 months or 4 months, there would come a person from the capital, from the headquarters of that state, to supervise you, but a supervision that was not the supervisor coming, you are doing this wrong or that. No, he would work with you to tell you how to do the things,
Yeah, it's
it was an incredible thing.
It's a remarkable kind of assignment to have. And was this a common thing for many of the medical students to go to, that sort of an experience? I just wondered, because today we have very few in the medical school class who will be interested in public health. And yet this was transforming for you. And I wondered, were there many others that got that experience, or were you pretty unique?
At that time, that was pretty unique. And we were 3 friends that did that. I had 2 other friends, colleagues from the same class, that also went to the same service. So I was in the Altamira in Pará State. Milton Arn, that you know also from the smallpox, worked in Óbidos, the Amazon River. And the third one, Eduardo Costa, which also worked with smallpox for a while, was in Boca do Acre, which was a very remote place near the Bolivian border. So, and it was very unique. But after we did that, then other classes started also trying to do that. So it opened kind of a door for the people, particularly from the south.
Does it exist to this day?
No, then, this was, in my opinion, the best public health service in the world that I knew it, and from my experience in other countries. And it was really you know, pitiful that eventually this disappeared. And disappeared because of jealousy of other organizations, because we were very well paid. You see, let's say we are better paid than the other bureaucrats. And that created lots of jealousies. And then eventually, you know, the service terminated. And I used to say that when this terminated, it was the end of public health in Brazil. Because, you know, then never we had a service like that. So that was an incredible experience. And then after 1 year, I thought I had learned everything, you know. And then I wrote to the School of Public, to the foundation, to the president of the foundation, to get a scholarship for public health. And he said that no, because the scholarships are already for older people, you know, and that was very young and blah, 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 you know. I said, okay, then I resign and I pay myself. So and then I resigned and,
Did you?
and then I paid my course. And it is an interesting vignette because this guy was called Jacques Noel Manceau. He's an epidemiologist, medical officer, and a statistician, very, very able, almost like a genius. He was by accident president of the foundation at that time. Later on, he was employed by WHO, and he was the only WHO advisor in Canada for the government of Canada. And then when that project finished, he came to Washington and became the chief statistician here. So I went to visit him because I needed help of statisticians for the EPI evaluations, because I went to do these cluster surveys and so on. And then I went to him and I said, look, you don't remember me, you don't even know who I am, but I'm Ciro de Quadros, I worked with CESP, and you are the one that refused to give me a scholarship. And then we became very good friends, and then I got married. He was even, you know, the godfather of my marriage, and I used to joke that my wife had married with him because I had to use his ring because I didn't have a ring, you know. So we became very good friends. And then later on, he had a very important, you know, role in Brazil when there was the fight with Sabin and the government. And Sabin had accused the government of, you know, of lying, you know, the cases. And then when the minister called me, I said, call Jacques Manceau and ask Jacques Manceau to analyze the whole thing and analyze the paper of Sabin, because Sabin had written a paper. So Manceau analyzed and destroyed the paper of Sabin, you know, and then they realized that they had to do something about it.
You moved on then after a bit to state of Paraná.
Yeah, no, so I finished the public health school. We had a very good experience there. It was the time of the protests in Brazil with the military group. We helped organize, you know, the biggest demonstration at that time in the country was the 100 million people, no, 100,000 people in the streets of Rio de Janeiro. And so we had fights with the director of the school. Eventually he had to resign, so we won that battle. And then we finished the course. During that period I had the privilege to work with the most famous anthropologists in Brazil at that time, the brothers Vilas Boas, and they were the ones that were protecting the Indians in the Amazon. And we were, myself and Milton went and spent few weeks there, and we applied the first time the BCG, the freeze-dried BCG in Brazil, because Brazil used the liquid form, and the guy that produced it didn't, he boycotted the freeze-dried. So these guys from the Indian Foundation imported the vaccine, and then we went, me and Milton, to vaccinate the whole park of the Xingu, you know. And one of the guys that had a big inflammation in the tooth, I had to take the tooth of this guy. He was a kid, you know. Later on, he became the chief of all this tribe, and he became a very famous national figure, because then the Indians start having more prominence in the country. So it was a very good year in the school. And by that time, the Brazilian government tried to organize a kind of a CDC, you know, for Brazil. And we were invited, myself and some other colleagues, to be part of that little group that was to create that center. And So we went there and we were, starting this. The director was a guy called Aristides Vallejo Frei, which was previous director of Butantan and had been consulting with PARM in different countries. It turned out that he had consulted in Cuba. And by that time we were trying to look at, the vaccine quality in Brazil, produced in Brazil and so on, particularly the influenza vaccine. And then we kind of sneaked out the vaccine from the Fiocruz and was tested abroad, and it was just like an egg soup. So the center denounced that.
Your position at that point, when you were taking out vaccine for external evaluation, you were doing what?
We were in this epidemiology center that we were looking at.
Oh, I see.
Yeah, it was from the center, epidemiology center, like a CDC.
Right.
And we went in Rio. In Rio. So it turned out that 6 months later, the head of the lab that produced the vaccine became minister. And of course, the first thing that is destroyed was the center. He fired everybody. He said, these are all communists. This guy was even in Cuba, so it's gone. And by that time, I think coincided more or less in time with a meeting in Uruguay that you were present. Mm-hmm. And you met there Nelson Luiz de Araújo Moraes, which was a vice minister in Brazil. And then you talked about, the surveillance and containment and so on. So Nelson came back very enthusiastic and said, okay, since we cannot do much, let's try to do surveillance and containment.
Right. It seemed to us at the time that Brazil was entirely wedded to the idea of vaccinating everybody. But in terms of how many cases there were, or following along what effect it was having, there was not much being done. And this is where Nelson Moraes at that time said that maybe we could set up to do sort of pilot studies in a number of states.
So the head of the...
What year was that?
That was 1969. So the head of the program was against this initiative. And he argued that because we want to do that, the government didn't have money to do the campaign in every state. So they had to go state by state. So there are several states that were not yet in the program. So we chose 3 states out of those to do that, which was Bahia, Minas Gerais, and Paraná. And the people from the campaign did not want to do that because they said that if we are going to vaccinate some few people, when they would come with the campaign, the statistics would not be good, because many people was already vaccinated, and then it was a stupid thing, that they did. But anyway, we started, and then I was assigned to Paraná State, which was an 8 million people at that time. I went there with nothing.
Your job was to eradicate smallpox.
Huh?
Well, your job was to lead the smallpox.
My job was to demonstrate that surveillance and containment could stop transmission. That was the job. So.
And that you set out to do, try to complete before they could start the mass vaccination campaign.
You see, so I went, and then I was so lucky again because I think everything in life depends of the moment and if you are in there at that time. I arrived there when the governor of the state was a 34, 35-year-old guy, extremely competent, charismatic. So I arrived one day, the next day, there was an office of the foundation, CESP, because this was the CESP Foundation, that took me to his office. And then his brother was a journalist because everything this guy did was also political, you see? And the next day comes a headline in the main paper. Starts here the end of smallpox. You see?
The beginning of the end.
The beginning of the end. So.
The assignment of one person. That was,
And then I said to the guy what we needed, and then he assigned me a nurse, a guy, and a vehicle with a driver. And I said, we need to organize a surveillance system, you see. And how do we do that? I said, look, we have these aerograms. And then every, clinic has to send this aerogram back to us every week. And then, but if there is no clinic, then we get the mayor to do that. So we involve anybody that can do it. So we started that, and then we started getting reports. So then I started going out and finding lots of smallpox. And then I would come back, write the famous report, and then you'd put in the newspaper. Every time, every week, there was a newspaper article on the smallpox. And the guy became a...
The conclusion I think you came to was that 2% of the cases were being reported.
Yeah,
is that right?
yeah, at least, yeah, that was... then we looked not only in Paraná, but the other states that we were working, then the average in Brazil was less than 2% was being reported. So we investigated, I don't remember, nearly 1,000 cases in the state, and we vaccinated about only 30,000 people, and transmission was totally interrupted. So when the campaign came, they went basically to every place. They didn't find any case of smallpox. So it demonstrated that this really worked out.
Well, and also your resources were limited. You had a car and a driver and a nurse.
Yeah, and the car was taken with the most difficulty, because the guys in Rio didn't want to give me the car. So I took a bus, I paid myself and went to Rio. And I said to the guy, if you guys don't give me a car, I will not do this. You see, so then by that time they had changed the head of the program, and it was Osvaldo Silva, very good man. He said, no, you will get the car. And then I drove back the car. So it was fine. And I think that was extremely, also a very good experience. And there is a thing that is very important, that 30 years later, in the commemoration of the 30th anniversary of the last case of smallpox in this state, the Secretary of Health, which was also very similar to the previous one, very charismatic, he did not know me, but through people, he called me and asked if I could go for this commemoration. And I had told him the history, during this conversation, of the role that Paraná had taken on that, the reporting, the surveillance, the aerograms, and all this, I said, wow, that's fantastic. So in the day of the ceremony, he brought the old governor at that time. He brought the widow of the secretary of that time and the children of the guy. Even Bichat, that was now living in Paraná, I gave an interview in the morning in the news, in the television, and his wife saw it and called me and said, can Bichat go? I said, of course, but Bichat had Alzheimer. So he was in a wheelchair, in the ceremony, but he was there. There was all the people from the Secretary of Health that were still alive. It was a beautiful ceremony. And the most important thing, which the Secretary had not told me, at the end he took us to the hall of the palace, and there were computers all over. He said, Ciro, do you know what's this for? It's for the modern surveillance system. I'm giving one to each mayor. So each mayorship will have a computer to report diseases. Isn't that beautiful?
Yeah, beautiful.
And the previous secretary, the one that when I was there, then I left to Ethiopia, invited me, he was elected deputy for the parliament, the highest votes in the history of Brazil. But then he died before 40 with leukemia. So if he had not died, this guy would become president. He was a charismatic guy.
You were pretty charismatic yourself, and I remember meeting you at one point in time. We had a bit of a discussion about your writing up all of the reports of outbreaks.
Yeah, that was very interesting, yeah.
Well, I was very impressed with the detail that was there, and the tables laid out, cases by age and epidemic curve, everything beautifully done. I couldn't read the Portuguese, but I was doing fairly well getting through it. And I said to Ciro, I mean, this is wonderful, Ciro, but you don't really have to spend all this time writing up all these outbreaks, as you've done so many. And he looked at me and he said, but I have to come in Saturday night to get supplies and go out Sunday. I can get it done before I have to go back out in the field. And they were magnificent reports, so that a little later I got the message that you and the other two who were assigned were terminated, I think, with a change in government, if I recall.
Yeah, because of this issue of the minister that became a minister was the director of this lab that produced this bad vaccine. And then he dismantled the whole operation because he thought that this was a communist kind of thing. At that time it was, if you want to get rid of somebody, you call them the communists and you are out. So, but anyway, the experience in Paraná was also life-changing in a sense because, you know, because of, again, the timing and the whole thing. You could have visited any place in Brazil when you went, but by chance you went to Paraná, where I was. So if you had gone to other states, I would not be sitting here today.
So based on that visit, you offered him a job.
I did. Actually, I was very impressed with the very minimal resources that he had, how much had been done so quickly in this state with very little. And obviously, he was a field man who really knew what he was doing. And at that time, we were just starting up in Ethiopia, which was with just about no resources. We had very few people and very little experience. And so it seemed to me this would be, as a person in the field chief, if you will, of the program, it would be ideal. And so I offered him the position that this seemed like it was an awfully good idea. And I think at that time you were just getting into your English.
Yeah, I didn't understand much, but one thing I kept in my mind, because when we said goodbye, you said, I would like to have you in my team. This I recall.
Well, it was one of the best things that we did. And I think what it did demonstrate, though, that with a very good, one good person getting the resources mustered to attack a problem, you can certainly do a lot. And going on to Ethiopia, you certainly had your hands full.
Absolutely, and I was very afraid of going because, you know, my English was very poor. So I got, when I got the invitation letter, you see, I said I have to accept, and but I have to do something about. So I got a private teacher, you know, to teach me or to help me with that, which was good. It happened that she had a sister in London that was an actress in the theater, and the husband also was an actress, the daughter was an actress. And then she said, spend some few days in London with my sister, you see, and then to brush your English. So I went and spent about 10 days there, or 1 week or 10 days, living in a hotel near the house of them, and I spent the whole day with them, which was very good. Met the family. One son worked with the Granada television, and the daughter was an actress. By that time, the daughter had been selected by Roman Polanski to play Lady Macbeth, the film. So we had a big party, you know, with Polanski and all these people, you know, in the house. And so it was very nice. And it helped me a lot. And then I went to Geneva and met with you, and then you sent me to India for that big meeting. And then at a certain point in the meeting, John, with all this full of people from, he asked me to make comments about my work in Brazil. I do not know. I would like to have the recording of that to say what did I say.
Well, you know what I remember when I worked with you during those polio years, he was always doing a crossword puzzle. And I found that he could do a crossword puzzle probably, and they were the New York Times crossword puzzles. He could do it 5 times faster than I could. In fact, I wouldn't be able to finish, but his English, he always worked on it day and day in an
and still my kids correct me. So,
well, at any rate, the situation in Ethiopia was very, very difficult. The Ethiopian government, let's say, we were blocked from beginning a program in Ethiopia because of an AID program for malaria. And they would not even allow me to come down to talk with them about doing an eradication program. So that it was the very last country, endemic country, with smallpox and no program. And through a series of circumstances, at any rate, they finally assented to go with the program. We had a man, a German chap, who had been head of the Imperial Guard.
Austrian.
Yep, Austrian, he was, right. And he was very influential with the Emperor, and that was very helpful in getting the program started. But Ciro was there, and it was this man from this Austrian fellow and the Ciro, and I think we got that by that time we had some 10 or 12 Peace Corps.
17.
Was it 17? 17 U.S. Peace Corps. And the Ethiopians were not well staffed. They didn't have an awful lot of trained people, and I think we probably had not more than 10 or 15 Ethiopians.
We had about 17 or 20. We had 17 to pair with the Peace Corps, and then we had 2 or 3 in the office, in the main office in Addis Ababa. You know, the administrator, who was Teferi Seyum, and then we had the secretaries, 2 secretaries, and we had a sort of a guy that used to take care of the office and the supplies and so on.
And I don't think many people really appreciate just how big Ethiopia is. I mean, it's twice the size of Texas.
Yeah, particularly the ones that planned the program. Because they planned the program with 30 people, 5 vehicles, for a country that is bigger than Texas, you know, with 30 million people,
and virtually no roads.
And no roads, you know, and so that was it. And that was really, but it was fun because, you know, we had to learn to do, and we decided then to start working in the southwestern provinces, which were better staffed by health people, because the departments were run by the Swedish in those 4 provinces. So that we had then a good support there. And we said, let's work only in those 4 provinces, and in the others, let's just have the people that are assigned just to report or to do whatever they can with the local resources. And I think they did a fantastic job because, you know, in the first few months, we reported over 25,000 cases of smallpox, which generated a very strong letter of DA Henderson saying, are you guys reporting rumors? I said, I can show you the epidemiological form for every single patient with all the data.
It really impressed me. I was dumbfounded. Here he was with this little band of people, no real reporting system in Ethiopia that you could identify. And the history in Ethiopia, they'd been reporting, I think, 350, 400 cases a year. And we had gone to do some planning to try and get some sort of a program started. We didn't have much money. And people reported they'd seen no smallpox. And it was, smallpox was just not around. And we were getting the impression that maybe the population is so sparsely scattered that we're not, probably smallpox may be just sporadic, and we would probably could handle this with fewer people, but the best we could come up with was 5 vehicles. Imagine for a country like this, and the number of people we could get, that's about all we could provide. I think the Peace Corps, and later we got Japanese Peace Corps and some Austrian Peace
also.
Corps. Anybody who would like to volunteer. But it was basically an unstructured situation with no history of reporting of anything centrally, and taking this country, which was incredible, and Ciro took over, and you might say just a word or two. How did you do it?
It was the first country, I think, in the world that started from day one with surveillance and containment. So there was no, like the first country in the world. We generated lots of questions. For instance, the director of the Communicable Diseases Hospital, Infectious Diseases Hospital, a Greek guy called Dr. Papaioueno, went to the emperor and he said, look, Ethiopia had no smallpox. These guys come here. They say there are lots of cases, but they don't vaccinate anybody. Because we are vaccinating just the containment.
Yeah.
See very few people being vaccinated. You see, so generate those kinds of questioning until we had to explain and educate the people. Turned out at the end, Papayan was expelled from the country because he was doing false reports of things. And we transformed the hospital, because smallpox was not prevalent anymore, into our offices. So we had our headquarters in the previous, smallpox hospital.
Amazing.
I think I mentioned this one time to you, that I was talking to a former Peace Corps volunteer that had been working in Ethiopia, and your name came up. And he mentioned going out into the field, the role of active surveillance that you clearly identified as a key strategy. But so he's going out to the field on a donkey in some isolated area, and he wakes up in the morning, the sun's just coming up, he's on the ground in his sleeping bag, and he puts the covers back over and says, I think I'll sleep another half hour. And then, just about then, he hears the rustles in the bushes, and it's Ciro coming on his donkey, catching him asleep. And he told me the story. I laughed. It was
this
so
was
funny.
Vince Radke, a Peace Corps that's now in CDC. Actually, he got an award. Now he worked in environmental issues in CDC. Very, very nice man.
But he also said that he never slept in again after that. He never knew when Ciro was going to turn up.
This was the most difficult area to reach, because it was the southern part of Jima province, which is in the southwest, and they had the tsetse fly there. So, it's very difficult to get, animals to rent and all those things. It's hard to get there. There was an airplane that used to go once a week, and actually after the week that I stayed there, when we are taking off, the plane got stuck in the mud. So all the passengers had to go out and push the plane, this DC-3. So it was a very remote place to get. So anyway, but I think that, at the end of the whole thing, we had, the first 3 years with much difficulty. Then we start getting additional equipment, camping equipment, vehicles, which then start improving the program. We start getting very good collaboration from several of the local health officials. I identified very good people, like Bonaor and many others that, Zain Ahmed, that became leaders of the program. So we could identify those people. And then, 3 years later, came the revolution, and then, came other variables that were not foreseen, which was very difficult. During this revolution, all international programs stopped, with the exception of smallpox.
How long were you there?
I was there for 6 years.
Yeah.
So 3 years with the emperor and 3 years with the socialist government.
Well, you had the emperor was assassinated. It was a Marxist takeover of the government. And it was such that the foreign assistance people from all countries were evacuated. And there was only one group that was allowed out of the capital of Addis Ababa, and that was a smallpox group.
Yeah.
How did you ever persuade them?
I
to
think
let
that
you?
was basically, I think, a connection between Kurt Weithaler, who was the previous director of the Imperial Bodyguard Hospital, and his connection with the Ethiopians. I think that was a key figure in negotiating that, with the condition that, because by that time we had already 5 helicopters in the program, we finally got them good support for going around. We had 2 fixed-wing aircrafts, and then they allowed also the aircrafts to continue flying, the only ones particularly aircraft that were flying, because they were afraid of the smuggling of the money out and people out and so on. But with the condition that they put one government official in the helicopter, in the plane. And then we negotiated back, that's fine with us, but provided that he speaks the language where we are going to work, because then we don't need the interpreter. And also with the proviso that they should not use an arm, a gun, which was, at the end, did not turn true, but that saved lives. Because once, when we are operating in a very difficult area of the mountains of Ethiopia, central Ethiopia, we used to send the teams in the morning, drop them by helicopter in the evening, late afternoon, the helicopter would go back to the village to pick them up. So I was in the camp, and then the helicopter went and never came back. So we were really worried. We didn't know where they were, you know, up in the mountain. Then I was in the house of the governor of that area. And then finally, you know, around midnight or something, somebody comes and said that the helicopter had been blown out. And then the next morning, then the people came, the pilot and the people that were with him. And then they told the whole story that the guy that threw the hand grenade in the helicopter was a priest that thought that these were Muslims coming to change their religion and so on, you know. And the helicopter was taking off, and usually kids would throw stones and things like that, but this was a grenade. So the grenade exploded, the helicopter came down, and the guy from the government started shooting. So he had a gun, you know, he started shooting. And then everybody dispersed and they went away. So at the end, you know, the prohibition, if he had not had the gun, then maybe there would be a problem.
So the folks inside the helicopter survived?
So everybody survived because it was not very high. So the helicopter still could land, they went away and the thing exploded. This helicopter, the carcass is still there as a monument, you know.
You know, we lost another helicopter that went down in the lake, I think, at one point.
We lost another one when we were moving camp also. I think the pilot overloaded the helicopter. So when it took off, there was a huge cliff. So he took off and then he realized he could not make it. Then he tried to come back and then it land crashed. And then, but nobody was harmed also.
And I think one was held for ransom too.
That was in the Ogaden when they kidnapped the pilot. But I was already out there when that happened. But we had another one. The first one, the first helicopter came, and in the first flight, you know, everybody of course comes to look, you know, what is. And in Ethiopia, everybody wears a stick, you know. So this guy comes and hit the blade and broke the blade.
Okay.
So we were stuck in this area for several weeks until the blade would come back from Canada.
It's hard to imagine all the difficulties were there, but I think one problem you had was how did you do surveillance? You've got very few health centers. You've got no communication, like central communication. How did you do surveillance?
We had, you see, we had in many provinces, there were, like in the southwest, we had, you know, run by the Swedish. So they had radio communication with Addis Ababa. So every morning I would go to the office of the Swedish people, and then I would talk to the province and get reports. From some ones were telephone, you know, from the provinces, sometimes aerograms. So we used all means of communication until we got, through the negotiations of you and Arita with Japan, we got the Japanese support. And then the Japanese, besides the few volunteers, they gave us vehicles, mechanics, and radio equipment. So every office now in the province had the radio, and then we had one in our headquarters, so that every morning, early morning, I would go to the office when I was in Addis and talk to everybody and got the reports. And then again, the same lessons I learned from you in the past of feedback and so on. From the outset, we had a newsletter that reported back, which actually the first issue even put an epidemiological note of an outbreak we had investigated in Tepe, you know. We got even a letter from Bill Fagg, that was director of CDC, congratulating us for such a fantastic newsletter, you know, bulletin. So, you know, so everybody had the whole thing.
Well, you had a lot of objections in some of the tribal groups, didn't you, on vaccination?
The highlands were extremely difficult because of the resistance. You see this blowing up of the helicopter, you know, that was, so we would spend weeks and, you know, days and weeks in the field, and we'd go back, and luckily the vaccinators and the Ethiopians were very honest, because they never lied that they were vaccinating people or whatever. They would say, look, we found case and they don't allow vaccination. So they were very honest. So we had to go through again and again with the priests, the governors, the chiefs of the villages to get the thing going, but it was very difficult. you know, like in not only in the highlands, but in the area of near the Djibouti area, all that kind of the Danakil depression, which was dominated by a sultan. You know, you could not even refer to the emperor because they would kick you out. And they kicked us out actually from there, throwing stones and spears and so on. But then finally we could get rid of the sultan. You see, we could get access to him. And then I explained to him what needed. He said, don't worry, from now on you will have no problem. And then he put people with us, we vaccinated everybody, and went away. So it was a matter of dialogue with those people, but it was very, very difficult because of the resistance.
Community leaders, the
Yeah.
Sultan in this
Yeah.
case. Yeah.
I don't think that one looks at the problems of doing a program, and it's hard to identify a program that had fewer resources, more problems, everything. You had famines, you had floods, you had refugees, you had civil war.
And we had wars. We had the war in Eritrea, which was very complicated, but we had very good Eritreans in the program, and they could have good negotiations there. So that was not a big deal. They accepted. But in the Ogaden it was very difficult because the Somalis had this clash with Ethiopia. So, and of course the terrain was extremely difficult because of the desert, the distances, you know. Even with the helicopters sometimes was difficult. And then there was the harassment because while I was there, until I was there, I think we had 4 cars with the crew that were, you know, kidnapped and taken to Mogadishu. You see, so I had contact with the Somali ambassador because sometimes I played squash in the club there, and then he was there, and then I would talk to him, you know, and say, look, keep the car and the radio, but send the people back, you know. Then they would send the people back. So, but we lost some few cars and radios. And then we had, of course, the different attacks, you know. Sometimes the people from Somalia would attack. And there is even a very sad story because the fixed-wing aircrafts were run by an operation from Count von Rosen. Count von Rosen, very famous Swedish guy that, you know, had fought in Biafra, you know, helped the Biafra revolution and so on. And he and his son ran this operation. So they had we had the DC-3 that carried the fuel and the food. We had the 2 Saab Safaris, fixed wing, and we had 5 helicopters. And von Rosen used to go to the Ogaden because the governor was an Air Force guy that was trained by him in Sweden, so he was a very good friend. He usually stayed in our camp, but when this guy became governor, he stayed with the governor. And the governor compound was attacked, and everybody was killed, including von Rosen. You see? And he always used to say how he went to die, because he was already 6 or whatever. He said, I went to die in a crash of a plane. I went to die piloting. And the poor guys killed by the Somalis there in the camp.
Did you ever personally feel this was it? This is the end of, that you fear for your life?
No, because let's say you have a little feeling, but as I said, you know, when you are in the middle of the thing, you don't realize the magnitude, because you are part of that process. Only when you leave, only when I came out of Ethiopia, is that I said there was a war there.
Yeah.
That was hell.
Yeah.
And you know, but I was there, and when the whole curfews came and all those kinds of things, you know, I used to travel from province to province in my Toyota in the evening, so to avoid things. And now, today I realize that that was extremely dangerous also, you know, because I would put the lights on in the car, but people could think that I was bringing a bomb or whatever and fire at the car. But anyway, you do those things.
I remember flying with one of the helicopters in Ethiopia, and we were flying quite low, and I said, wouldn't it be a good idea if we could maybe fly a little bit higher because I could see little metal things coming up, and people were obviously shooting at the helicopter. And he said, "Well, I don't know, Doc. We heard they got ground-to-air missiles last month, and we decided we'd fly higher." So, yeah, this was going on. They were at risk in a very major way throughout this whole event. But what was impressive, Ciro, in all of this was your ability of keeping a very disparate group really working well. All the Peace Corps people, the Ethiopian health officers were an extraordinary group of people. The Japanese Peace Corps, the Austrian group, a lot of volunteers came in there, a lot of things. Somehow there was an orchestrated effort, which was really impressive.
Yeah, it was a collective action at its best. I think everybody performed really very well. We had few exceptions, as you always have, you know. And actually even foreigners, you know. We had a case of an Italian epidemiologist that, you know, said that his province was free, that the cases were coming from the other side of the border. And then we found out that he was paying the guys to say that they were from the other side.
Oh, gosh.
Yeah, I think you remember the name of this guy. You know? So we had those kinds of things, you see. But,
we fired.
yeah, but you see, those things happened. But in general, I think the performance was fair, and the dedication. You see, we had people, you know, like Jean-Paul Riest, that would even refuse to fly in the helicopter, said, "No, I want to walk." So this guy would walk from village to village in the desert, you see. And one day he was in Kalafo, you know, which is in the border of Somalia and Ethiopia. And there was a big flood because the Kalafo River during the rains would flood the whole town. So this guy was stuck in a little hill for several days until we could get the help from the army to go to drop me there and bring the guy. So I went, and then I had to walk with water in my chest in a place full of thorns, because that was the desert. So it was thorns. It was very difficult to walk on that thing. And so we took Jean-Paul out after several days. We had another guy from Egypt, Mohammed El Nagar, that went to the Ogaden, even with his family and 2 babies. You see, and his village once was attacked. They were also, you know, sieged by the guerrillas, and also they had to be withdrawn from there. So it was tough. It was very challenge after challenge, until we got the last case, which we thought was the last in the world. You came, Demo. We had a big party, and in the middle of the party there in our camp, we got reports of a case in Harar. And next morning we flew immediately. Me and DA flew and went to the village. It was a chicken pox, so we were okay. And I kept telling DA, look, we have cases in Somalia. And he said, Somalia is clean. I said, we have cases in Somalia. Somalia is clean. Until the fatigued January 1977, that finally you got the cases. And then he found out that the WR was lying. And hiding the cases.
The WHO representative was responsible. He knew it. And we had a few exchange of a few words over that. But I think it was one of the most difficult countries that one could imagine. India was huge and big and complicated, but this was certainly really a tough assignment. But during this time, we had, meanwhile, we had seeing what the smallpox program and how much could be done by vaccinators with some organization and participation of villagers, that we were, African vaccinators were averaging 500 vaccinations per day. And a team of 4 does 2,000 people a day, and they were doing it very well. And I think at that time, the question came to us, well, why don't we do something else? We got the DPT vaccine, polio, measles. These are in use in other countries and in an industrialized world. And wouldn't it make sense to expand the immunization program to include other vaccines, and then in '74 we got a commitment with the Assembly to undertake this with virtually no resources, of course. But then Ciro was wrapping up in Ethiopia and recruited them to begin a program, or this program in the Americas, the expanded program on immunization, again with almost nothing in the way of resources, very few, no precedence here as to what this would constitute, only that it was a good idea to be giving a number of different vaccines, and that this should be an expanded program, expanded beyond smallpox. And so I think it was 1977.
Yeah, but I think we have to go back some few years, because I think there was an event that was transformative of this whole thing, and that really kind of consolidated the idea. And that was a meeting here in Paro that has a very important scientific publication called The Control of Bacterial, Viral, and Rickettsial Diseases. And there was a session in that meeting that you participated, which was which vaccines to use and how the programs should be organized. So that chapter of that book is the origin of EPI, Gavi, or whatever you talk about, anything in vaccination. That was the milestone that set the stage. So I think that was a very important thing that we should keep in mind. I forgot the number of the scientific publication. I have one of them, is a book of this thick. The chair of this committee that you were was Sulianti Saroso from Indonesia. And you see that set the stage, and you were the secretary for that
Well,
meeting.
that was an important meeting, and the genesis of it was that Merck had come to us in Geneva, and I was smallpox and the head of virus diseases, Charles Kilburn, and they wanted, would they make available money to put on a program on measles? And we said no, we couldn't do that, just measles, and they would be just the only company that had measles vaccine at that point. So we argued the case about could we have a program on immunization, and there would be include measles, and would they be willing to support that? So after a bit of back and forth, they finally decided they would. And so the meeting was called, and Julie Sulianti Saroso was at that time was a Director General, I think, for communicable diseases, or maybe she was higher than that. She came as was made the chairman of it, and we had quite a number of people in. It was here in Palo, and it's a very thick document with a lot of good papers, really good papers. And Ciro's right. I think this is where the idea that we could do quite a bit with vaccination, which at that time, and as I look back on it now, realize there was no country, none of the developing countries in the world had a national program of vaccination for anything. And that, so that the idea of going to, let's say these are the common vaccines, DPT, measles, and polio, and extending it to include all of these, it was a nice idea and sounded very good. The only trouble was you had to implement it. And so the idea was there. And so Ciro was the first director of a regional program dealing with EPI, with very little to guide anything here, except that it really would be a good idea to somehow or other give these multiple vaccines and have this the national program. And so
I arrived in Washington, so I go from, DA calls me in Addis Ababa and say, look, the director of PAR is here and he wants to talk to you. And then I fly to Geneva. It was actually your farewell party, which was very nice. I attended that, and then I had lunch with Dr. Acuña, Hector Acuña from Mexico, who was the new director. He wanted to bring new dynamism and young people to the organization. So we had a nice conversation in Geneva, and then I accept to come.
You were how old at that time?
I was 37.
Gosh,
So
that was quite senior.
So I came, and I came in a February night, the Potomac was frozen. It was when the cars were driving across. There was the energy crisis, and there was no illumination in Washington. All the monuments were dark. I said, what the hell am I doing here? And then I was put in the Allen Lee Hotel here in the side of Pajo. And this was a Saturday night. And then there was 9 o'clock in the night, and then there was a message from the guy that was to be my boss, Carl Wester. Said, I am in the office, give me a call. So I called the office 9:30 in the morning, in the evening, said, come here. So I came, and then said, let me show you your room and where you are going to be, and then he showed me, it was 9th floor. I entered in the room, there was an empty desk and an empty shelf, absolutely nothing. So that will be your digs, you see. And then he drove me around in Georgetown, saying, this is Georgetown, and this is this, and they showed me the town in the evening. Okay, then Monday I come to the office, and what do I do now? Where are the archives? Where is the memory of the immunization here, you know? Nothing. So it's okay, let's create a sort of a task force, you know, that can look at this issue. And I think we were very lucky in a sense, because you know, this was the period that Alma Ata was being generated, in a sense, the conference of Alma Ata. So there was this interest in the renewal of the principles of global health. One of the guys there was a new director general, Mahler, which was a young guy, very dynamic. Here in Pajo, Hector Acuna also, which wanted to bring new life, new blood to the organization. And David Tejada was an assistant director general. He's a Peruvian guy, a very brilliant fellow. And he had been actually my professor in my public health school in Brazil, because he was teaching there. And so this was a good environment for new things. So we created a task force that for the first time included people from every division of Pajo, including administration, you know, everybody. It was everybody to be involved. And then we prepared the documentation of how this program could run, because there was nobody knew what TPI was, you know. Even Geneva didn't write anything about it at that time. So there were the general principles of the resolution in '74, but it was not translated into a workable thing.
How to do it.
How to do it.
Yeah.
So I had to write, you know, from my mind, whatever I thought it was, and present to the task force and make modifications and this and that. So then we had that. And then for the first time, also, which I think was also very important from the point of view of the policies of the organization, we created a subcommittee of the executive committee, you see, which were 3 people from the executive committee that were then to examine this proposal before the executive committee would do. See, nowadays you have the program, you have lots of things like that. That time did not exist, was the first time, you see. And I recall that the representatives were a guy from the United States, which I forgot his name, Roderick Dogdin from Trinidad and Tobago, and another guy from Nicaragua also. Those were the 3 guys. So they examined the documents, we worked 3 days together, and then went to the committee, and then went to the council, and it was approved. So this was important. Then I think we had, between 77 and 81, which was when we were trying then to figure out really how to shape this program, I thought that this had to be done from the bottom up, so that we should get the countries, you know, involved in the process. What should this program look like? So first of all, we had to have a country manager. So we had to ask the countries to nominate someone that we could dialogue with. So who is your guy in immunization? Oh, no, it's the director of health service, the director of epidemiology. No, this guy has lots of things in his plate. Who is the one that every day will think about vaccines and immunization? Can you appoint someone like, okay, then they appointed. And then if you look at the newsletter #1 of April of '79, then I published for the first time, I had the whole list of the guys. And then I published, these are the API managers of the Americas. And then we start putting those people together. For anything we would do, we would call some of them. So then we had them to start training this.
We need to change things.
Okay. So as I said, we asked the governments to appoint the managers. Everybody took some time, but they got their act together, and then we published that, the names in the, what we call the API newsletter, which was something that from the outset we thought we should have a feedback to the countries. So we established this API newsletter for the exchange of ideas, information, and so on. So now we had the managers. So now what to do? So we had to train them. So, but how do we train them? So I called 4 or 5 of them to Washington and said, look guys, now you are managers of this program, and what do you need to know, to do better job? So then in that brainstorming, which lasts a few days here in Washington, we decided that they need to have a module that discusses the diseases included in the program, the epidemiology of the diseases. We need to have a module that talked about the vaccines that protected against them. We need to have a module to teach how to maintain the vaccine in a cold chain. We need to have a module to teach how to do surveillance to see if your program was having impact or not. A module to the information systems, the immunization coverage, and so on. And the module on evaluation. So that then became the standard training exercise and training modules, which then, more than 15,000 health workers have been trained, because we did in cascade. We trained first the national level, provincial level, and then district level, and all the levels.
And just to parenthetically note, this was the beginning of the expanded program in immunization in the Americas, but it was really the first program of expanded immunization anywhere. And you're really beginning, even writing the manuals, right from the very beginning.
Yeah.
There was really nothing there, and I think this is important because this is really a very creative, difficult task, which I was really quite
Geneva
impressed.
tried to do that, and actually even we helped them together with CDC. We even paid, because at that time Geneva didn't have enough money. We had some few monies here. But the modules that CDC prepared were so complicated that, in the tests, it was simply a no-go. Everybody said, nobody will learn me these things. They had these incredible flow charts that cover whole walls, and it was like a nightmare. So I said, look, this is a no-go, so we had to prepare the things, and then it was extremely successful. So we had that component, which I think was one of the bases, you see. Then the second base was that then Alma-Ata happened, and then the 8 components, immunization was one of them. So we said, how can now we insert immunization in primary health care? How can we do that? What's the role of primary health care and immunization in that context? And then what we decided to do was to call a meeting with all the governments, all the people from the Ministry of Health, and all departments of power, including administration. And then we had 2 meetings, one in the Caribbean and one in Latin America. And then those meetings generated this publication, which is scientific publication 417, which is called Immunization and Primary Health Care, Problems and Solutions.
What year?
This was published in 1981. We had a meeting in Jamaica. We had a meeting in Ecuador in May 81 and in September 81 in Jamaica. And then we published the book. There is no authorship. The authors are all the list of participants that are in the end of the book. So that's collective action. Everybody is owner of this now. And what we did here is that we look at the different components of the program. You see, like, what's the role of EPI in primary health care was the introduction. Then what are the problems and solutions in the area of programming and evaluation of your programs? What are the problems and solutions to increase coverage? What's the problem and solutions for better supervision and continuing education? for the cold chain, for the community participation, for coordination among all the actors, for the staff training, surveillance and information. And finally, something that was not heard of in programs before, which was financing. How do you finance? And how do you manage this? You see, so, and for each chapter we had problem and solution, problem and solution. And then, okay, that's the second pillar. Now we know what are our problems, and we know, or we think we know, how we can solve them. So let's try that.
In listening to you tell that story, what's incredible to me, at least, is that you got the buy-in of everybody. So it wasn't just the immunization team. It was the folks working on primary care. It was the folks working on diarrhea, other interventions. You got everybody to buy in.
And the administration, you know,
Yeah,
finance people, the budget people, the procurement people, everybody was involved, was part of the team, and they participated in all meetings. So they were part, it was their program, it was not Ciro the Quadros or EPI or whatever, it was the organization program. I don't think we ever had in the organization a program like that everybody was the owner. Everybody felt proud of that. So that's a very important thing. Then we had a third pillar, or a third base, which was the, okay, now we are start working, you guys are trained, everybody now is implementing, so let's evaluate what you are doing. You see, how do we do that now? Okay, let's do a multidisciplinary evaluation. Let's get people from different, you know, realms of public health, you know, financing, management, planning, epidemiology. Let's get all these folks together. Let's go to a country. Let's invite a couple, 2 or 3 managers from other countries to go together so that they could, you know, have a peer-to-peer kind of thing. And then let's get to the government and then get people now from the Ministry of Health to be part of the team, from the different departments. And then get also people from the provinces that we are going to visit. So that in the end, the team was more than 70 or 80 people. And then we would go to choose the clinics and the health facilities according to, you know, discussion with the government. We chose provinces that were thinking performing well or not performing very good or regular, so a sample of the country, difficulty in access or whatever. And then we send teams, you know, to all those places to interview people. Hospitals, clinics, health centers, you know, and then write a report. This is an exercise that lasted for 2 weeks. I think you guys still do that.
Yeah. It still is.
Yeah, and then in one time, and then we had that guy, Steve Jones helped me a lot in putting together that. But we didn't have a methodology that was written. We were doing by doing. Yeah. So then I invited a guy that was a methodologist in evaluations called Enrique Rosenblatt from Argentina. He was exiled in Venezuela at that time. I found him there. And I said to Enrique, you go with me now to this evaluation, and I want you, the only thing you have to do is to, minute by minute, to say what we do since we arrived in the airport. You see, so the guy went, and it was the, okay, arrived in the airport, went to the hotel, next day or next, went to the ministry, met, and then we had the methodology, everything that was done. So that was the manual for evaluation, which was done like that. And I think that was, in my opinion, the third pillar, because we identified again the constraints and the possible solutions. And we had, as we had in this document here, the template for the program, which was, what is the problem? What's the quantifiable objective, you know, in relation to the problem? This form evolved over the years, but this was the original one. Then what activities I need to implement to arrive at that, when that will be done, in which quarter of the year, who is the responsible for doing that, how much does it cost, and where the money comes from. So then, you know, that evaluation produced this plan of action that then became standard to the program. So that was the third pillar. And then the fourth pillar, in my opinion, was the creation of the EPI revolving fund for the purchase of vaccines and other related supplies, which was established in '79 by the resolution. which then allowed for the countries to have the vaccine on time and pay in local currency. So it facilitates that they had access then to the vaccine. But you had to sustain that. So sustainability was a key for that. In my opinion, the program was sustained by two things that were involved here. One was the creation of the Technical Advisory Group, the TAG, which you were the chairman for several years, that then put together every year the countries in a meeting for a peer-to-peer exchange. And that creates, again, collective action at its best and an incredible esprit de corps. So that became really a family of people, you know, working in that activity. And they were happy, they were, you know, delighted to be part of that family. And the other thing on top of that was that every year the program was reviewed by the directing council. So that every year the minister had to come and report. And one day, the minister of Venezuela, in one of the meetings, he asked for the floor and said, Mr. President and colleagues, do you know why we have good immunization programs? Because every year we have to come to Washington and tell the Quadros what we are doing.
So the directing council...
it was true, because, you know, if they have to come and say something, they have to do something, you know.
The directing council is PAHO's annual meeting of all the ministers of health.
Yeah.
It's our governing body.
So this is, you know, these for me were the two things that maintain the sustainability of the program.
Now, we should ask, where did all this money come from? But to do this, did you have large grants from?
No, we had in the beginning between 78 and 85, we had not much money. We had, PAHO had assigned some money, Geneva had assigned some money. We got a staff, I got one person in the Caribbean to work for the Caribbean. I had 2 people, and I had 4 people in the field. 2 in Lima that worked for the Andean area, and that was all.
That was it?
Yeah, that was it until 1984. And then, of course, that the program was a program that was running extremely well in terms of increasing coverage, in terms of commitment of the countries. Countries starting to put more money. New vaccines start being introduced.
The countries themselves were having the finances.
At that time, they were not financing all, but they start then getting motivated to put more money. And in PAHO, besides what we had in the API department, you know, the other departments always, you know, helped here and there, because it was a program of the organization in a sense. But then comes this thing that we need to stress the issue of surveillance, because it was basically a vaccination program. It was not yet a disease control program, because surveillance, although were being implemented, was not properly done. And then, by that time, then Macedo became director of PAHO. And we talked several times about, you know, the program. He gave very high priority to the program. And then it comes also with the timing, you know, of the UCI, the Universal Child Immunization that Jim Grant was advocating. And
Jim Grant being head of UNICEF at that time.
At that time. I had met Jim Grant through the director of the Americas at that time, a lawyer from Venezuela called Teresa Albanese, extremely, you know, competent, and she introduced me to Jim, actually in Cuba, in a meeting in Cuba. And then, you know, Jim sympathized with me, and I sympathized with him. He was very charismatic. We became, you know, not friends, but, you know, knowing each other. And then one day he came to Washington and to meet Carlyle, and Carlyle called me in his office, and Jim said, look, the Americas should give this example, and you should reach, you know, the UCI, you know. And Carlyle told me, he said, can we do that? I said, I think we can, but we need to have a disease banner. And then he asked me, what do you mean by that? I said, we should get polio and eradicate polio. Because then if you have to eradicate a disease, you need to have surveillance. So then you put the component of surveillance. He said, okay. Then Jim left, and then Carlyle called to my house again to his office alone and said, "What do you mean by that?" But Carlyle knew that could be done because he was a very close friend of Valdir Arcoverde, the Minister of Health of Brazil, who was a friend of us because he made his career in Rio Grande do Sul. You see, and then he knew that the national vaccination days in Brazil were having an impact. So Carlyle knew that this could be done. I said, but if you have any doubts, I can assemble a group of people here to advise you. He said, fine. Then I invite D.A. Henderson, Bill Fege, I think Alan Heeman, Jesus Kumate, and João Batista Rizzi. And I brought them to Washington to meet Carlyle.
Good.
And then, you know, they said, after lots of discussion, we present date and this and that, then the committee said, it can be done. So then, Carlyle...
I can speak for myself. I was chairman of that committee. And I came in as a very doubtful chairman, and this proposal of eradicating polio or eliminating it in the Americas seemed like a very dubious proposition until I heard from Ciro about some of the studies they were doing, the results they were getting, and I came away from it saying, I think he could do it. And so I was very supportive.
Yeah, actually,
as we all were.
Actually, I go even back in history, because in 80 or 81, I visited you and I said, because I was already thinking about the eradication of polio, and I said to Jay, look, what do you think about if we eradicate polio in the Americas? He said, no way. So I left, you know, with the tail under my legs and left very quiet. So this 3 or 4 years later, you know, after this meeting, he said, yes, and I'm going to learn Spanish to help. And then we eradicated polio and he never learned Spanish. But you see, that was an important thing because data changed things.
Yeah. Right.
And when we had the data, you know, it was possible. So then Carlyle said, let's do that, but let's do it in a very high level. Let's do this, use this to the highest political impact possible. And he put then Georgia Lynn, that was the deputy director or assistant director, to organize that. So he said, let's do a ceremony, you know, that will have the big figures of public health, you see. And then we had the big meeting in May '85, which you were also present. We had Rotary International that was also involved on that. We had UNICEF. We had the Inter-American Development Bank. We had then other public health figures like DA, Bill Fege, Alex Langmuir, the Nobel Prizes, you know, Fred Robbins and Thomas Weller. The third one could not come, that he was already dying at that time.
Jonas Salk was there.
Jonas Salk was there, Sabin was there, all the figures, Ted Kennedy. We had the room, several ministers of health, and then actually with Sabin and Salk was interesting because I invite Jonas, and Jonas said, oh, that's great, well, I'll be there. When I talked to Albert Sabin, he said, who is going to be there? I said, you know, this and this and this, Jonas Salk. Jonas, why Jonas? He said, because he was the first to develop the vaccine. He has to be there. He said, then I'm not coming.
But he came.
No, wait a second. I said, then I don't come. I said, fine, so you will miss a great opportunity to be in a historical event. And then it's fine, we departed. A few weeks later he called me and said, Ciro, I decided to come. I said, great. And there is another thing. The only guy that will speak in this meeting is Dr. Macedo. Nobody else will speak. Do you agree with that? Fine, no problem. So we had the meeting. Carlyle spoke, but then he asked, when they said, what needs to be done and so on, and then he asked, I was sitting behind me, he said, can you answer, Ciro? I said, look, I think we have already all the technical, you know, knowledge, you know, and I think what we need is a good management to organize the programs and implement strategies that will work. So that was my answer.
What I remember, one of my first days in 1989 when I came to work for you, my office was next door to you, and I heard this yelling, and I was surprised. And yo, you can't say that to him. He's a minister of health. And it went back and forth. And afterwards, things kind of settled down, and I kind of meekly put my head into Ciro's office. I said, who was that? And he said that was Albert Sabin. Discussing a trip to a country.
No, because Albert Sabin was very, you know, he was kind of very, you know, how do you call?
There's some considerable thought when in
Yeah.
Henderson a decision was made to have them sit with somebody in between. I forget who it was we decided to put between them so that they were sitting very close.
No, we had a picture that is all over the place, which was Macedo, Sabin, Salk, Langmuir, Thomas Weller, and myself. So that's a famous picture that they are together there. And then what I did also is the next day I had a seminar with Jonas Salk, and the following day a seminar with Sabin, so that they had their place there. But again, here again, is I think it's a very thing of the timing, the right moment, because Rotary was already, you know, with the idea of this
Raising
the polio eradication to be the goal of Rotary. We had several discussions with Rotary. Rotary was advised on this by Albert Sabin. Albert Sabin wanted to do the program totally independent from the Ministries of Health, as a sort of an army of vaccinators, you know, because the ministries are incompetent. And then I said, and Carlyle supported, that this has to be done inside the health system, because we don't want only to eradicate polio. The objective is to improve the immunization program, is to improve the health service delivery, and in the meantime eradicate polio as a bonus. So that's our goal.
Which the Taylor Commission showed
then
in its report.
supported that, and the latest book of Muraskin also mentions that. You see, that even the global level didn't follow the same thing.
That's right.
And that's where came the stalemate with Rotary, because Rotary was very dependent on the advice of Sabin. So we had several meetings, and then in one of the meetings, you know, we said very clearly that we want to do this in our way with the health systems and health services. If you want to do what Sabin wants to do, you can do it alone. So we were very blunt.
No, I think
And
this
then
is-
there was a guy which was a key figure in Rotary, which was the Secretary General Herbert Pigman. And then Pigman said, we are going to think about it. And then he came back a couple of weeks later and said, we go with Parro, and we are going to launch a program that will be called Polio Plus, because the plus is the EPI and is the other things. And that's the origin of Polio Plus. And I heard that then Sabin resigned from Rotary. So that's another
I
story.
think it's important that this event was really instrumental, I think, a major step forward in which you're looking at entire populations and a program here, and it was in multiple different countries. There was just nothing like this before. And to try to orchestrate all of this was amazing. I think to put it in context, Ciro, can you come up with sort of a rough estimate of what vaccination levels were like about the time or early on in let's say, the late 1970s?
You know, the vaccines used at that time was DPT, you know, BCG, TT, and few countries had polio and very few countries had measles. And coverage was below 20%.
Below 20%?
Of those, yeah, it was very low.
That's right.
And of course, that between then when we started in 77 until 81, 82, the coverage started going up. It was maybe already mid-50s, 60s, and so on. And with the launching of polio and the establishment of surveillance, the things start really get much better, because we start knowing better the situation in each country and how we could try to modify. But then, of course, this polio is launched. And then, before that, when I proposed to Macedo, we had to find out how much would be needed. So after that, we had to prepare a plan. And we prepared that, and then we went to shop for the money. You see, and then UNICEF, Teresa Albanese gave $500,000, you know, and then the Inter-American Bank, after several negotiations, we got about $5.5 million. Paula Fini was the Latin American person in the AID, and they accept to give 20 million, UNICEF to give 10 million. Actually, the 500,000 from Teresa Albanese was to the revolving fund. For Polly was 10 million. And Rotary pledged another 10 million. So, but at the end, Rotary gave over 35 million, and the AID gave over 40 million, and UNICEF also went maybe to 20 million. So in the end, we got $110 million. But we had those commitments before the program basically was launched. And that's what I keep saying, that you cannot launch a program of such magnitude if you don't have upfront the commitments that you will have the funds, because if not, you run into several problems, as we have seen, lately.
Well, getting contributions from a number of different countries like this must have been a bit of a problem, each of them with ideas as to how rapidly you should progress.
Yeah, this was another hurdle that we have to go through, because, we had the Inter-American Bank. Then we said, look, but we need to have two bodies to direct this program, to be very transparent and to be owned by everybody. One, we need to have a technical advisory group that will provide us to the science, that what we are doing is correct. So we need to have that body. So we create that body with several members. You are the chairman. Then we need to have a committee that put the agencies that are collaborating together, so that they work together and they understand the program, they participate in the meetings of the technical advisory group, and they understand how their money is going to be used, and they can have a say on that. You see, so that's very important. And we need to have a unified strategy, so that everybody will speak the same language, because at that time AID had a strategy, UNICEF had another one, and PAHO had ours, and Rotary was following us at that time, and the Inter-American Bank said, I don't want to know anything, just do it. You have the money, you do it. You see? So, but with UNICEF and the AID was a nightmare in the beginning. It came to such a point that I went to Macedo and said, look, we have to break out with AID, because like this is not possible. I said, go ahead and do it. Fight with them, you see? So I talked to them. I said, we're not going to a fight, so let's try to sit together. Then I said together, I drafted a document which is called EPI Policy and the Strategic Approaches in the Americas. And this was a joint statement by the ICC member agencies. It was a very short thing, because there was a discussion.
What are ICC? What does that stand
The Interagency Coordinating Committee. So
the
this
partner
had,
donors.
you see,
Yeah.
that the plan of action to eradicate polio was to promote the development of the EPI in the Americas and attain its objectives. First objective, eradicate the indigenous transmission of polio and set up a surveillance system in all levels that can investigate the disease. So that was the objectives. Everybody agreed. Then what are the approaches? Okay. Group 1 are countries infected with polio, so those countries need to have NIDs, because the ID was against NIDs. That we will do only in the countries that have polio. In the end, everybody did it. And then, had the national days, the surveillance, social mobilization, the surveillance and evaluation. So we had the bibliography, and we put this together in English and Spanish. Everybody signed, put the logo. And then I said, now every director of these agencies in Washington have to write to the representative in the country and say, this is our policy. So Carlyle wrote to all the representatives, Jim Grant wrote to all his representatives, and the ID wrote to their missions. This is what will be done in immunization now. Okay, fine with the ID, and UNICEF continued fighting, which was a hell, in some countries. Then I mentioned to Teresa Albanese, I said, look, what shall we do? Let's talk to Jim Grant. So Jim Grant calls all the representatives of UNICEF in Bogota, which was the regional office. Teresa Albanese organized this. He invited me to come. The whole morning I had to present the strategy and so on. And guys from UNICEF pushing back, because UNICEF is very decentralized, pushing back, particularly Italian guy that was representative in Peru, which was the leader of this you know. So I went back and answered the question, blah, 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 blah. And at the end of the morning, Jim banged the table and said, "This is the strategy of UNICEF, and I am accepting resignations if anybody don't like it."
That's great.
Finished the whole thing. Then we had a big party in the evening, and Teresa said, "Ciro, I was so nervous because if this failed, I would be fired or whatever." You know, she was very nervous that, you know, that Jim would get mad at her or whatever. But then after this, it was a paradise, because then UNICEF appointed Juan Aguilar as their polio guy, as their immunization guy. And then, you know, we became like this. So if Aguilar would go to a country, I did not need to go. If I would go, he did not need to go, because we were talking the same thing. And then the thing, you know, started rolling out very well. And we know, as you know, it was the time of very many difficulties in the countries, in many countries. The civil wars in Central America, the Sendero Luminoso in Peru. And those were problems that we had to overcome, which luckily we did, because it was the beginning of the whole Esquipulas movement in Central America, with Arias, you know, that eventually even got the Nobel Prize. Carlyle had launched an initiative called Health as a Bridge for Peace, so that helped put the countries together that were fighting, you know, meeting very frequently with immunization as the main vehicle. And all those events, you know, facilitated the negotiation with the guerrillas in El Salvador for days of tranquility. And even in Peru, you know, the Sendero collaborated, although we never dialogued with them, but we dialogued in an indirect way. Because, you know, I put Peter Carrasco in charge of the operation in Peru. He was doing a fantastic job. And then when we thought it was the last case, then I went to Peru, and we had, you know, radio interviews, television interviews, in which we asked for the collaboration of everybody, underline, everybody has to collaborate. These are the last cases in the hemisphere. This will be good for everybody, you know. And of course, that Sendero got that message. And when the vaccinators were going to different villages, in the evening sometimes they were planning to go to village A, but one of the helpers would say, "Look, better we go to village B today." Okay, let's go to village B. Village A was attacked by the Sendero. So you see, so they were giving the clues where to go and where not to go. And when the chief of Sendero was arrested, several other individuals were arrested, including many people working with the vaccinators. So even the Sendero collaborated. So we were very lucky in having, you know, these days of tranquility. With later on, Jim Grant took to Lebanon, to Afghanistan, to DRC, you know, and they succeeded.
In the first instance of the decision on days of tranquility, I might just say a word about that, because I think now it's talked about, but I don't think everybody realizes just how this began.
The idea was that we need to get to everybody in the country, to every, you know, village. And particularly in El Salvador, the majority of the country, particularly in the north, was controlled by guerrillas. So the idea then was, you know, together with UNICEF and the Archbishop of El Salvador and the Red Cross, to see if we could get 3 days per year that there would be no fight and that people could be vaccinated. But that required, of course, you know, lots of negotiations. The Archbishop participated, UNICEF participated, and we participated. So it came to a point that then the guerrillas wanted more information. Because everybody was saying, let's stop the war, let's stop the war. I said, okay, why should we stop the war? We needed information. So then it happened that we had a very you know, important figure here in Pau, which was a political advisor to the director, which is called Mark Schneider, that had been a Peace Corps in El Salvador, so that he knew some of the people involved in this guerrilla business, including some people that were in Washington as the representatives, underground representatives. So Schneider organized a meeting in a pub here in Georgetown for me to meet with this guy and give the information why we need the days of tranquility. And then I had a session with the guy in the lunch and explained to him why it was important, you know, that this was health, you know. If you are communist or non-communist, your communist people needs to be healthy and the non-communist needs to be healthy. Everybody needs to be healthy. It's good for everybody. Health as a bridge for peace. And then the information was sent to the field commanders and they agreed. So then we had 3 days of tranquility, which also the timing was very important because by that time the government of El Salvador, President Duarte, was having a sort of trying to dialogue with the guerrillas. So that was kind of parallel. So the ambience was good. So even we went in a caravan in the first meeting that Duarte met with the representatives of the guerrilla in La Palma, a little village in the north of El Salvador. And I still have a little palomita, a little, you know, dove of peace that they distributed, a little, you know, thing that I have. So it all coincided, you know, it was a right moment in history that people were trying to do something better.
You know, one thing that comes up over and over again with each of these stories is what you do with the unexpected, the emergency, the thing that you never thought was ever going to happen. And while you were talking about Peru, what I recall at that time, on top of that, there was the cholera pandemic that started in Peru at that time, and how you used it to your advantage.
No, we used as a, you know, we instead of polio days, they called, you know, sanitation days or whatever. I forgot the name, and they would distribute, you know, because we were vaccinating house to house because they were the last cases. Was the mop-ups, which in Peru we visited 2 million houses in a week, and in Colombia, I think you were involved 1 million houses in a week. And in those visits, they would give pamphlets about sanitation, washing the water, you know, prevention of cholera. So it was a good system of incorporating other activities. And of course, that the program was successful. I think that it helped a lot to establish the network of laboratories, which under the advice of TAG, we should not have too many labs. We should choose some nice labs that were able to be upgraded. I had at that time a very big decision to make because there was a group that wants to move with monoclonal antibodies. You see, and the group wants to move with the
PCR.
With the PCR. And I was pressured by those two groups, you know. So at the end I said, look, this PCR here looks really fantastic. And it was the time when it came the PCR in the cover of Science. You see, I said, look, these monoclonal antibodies are here forever. Let's get with the new thing, see how it goes, you know. And I think it was the right decision, you know. So, and then I send Pinheiro and Pete Hatch,
Francisco,
to visit all the countries that had polio lab and give me a report of which those labs could be upgraded, that had good people, that had conditions for that. And then they chose, you know, Argentina, Mexico, Brazil, Colombia, I forgot I think Chile, Venezuela. Yeah. So then we got the network and the thing started working, and later on it was expanded because then it moved into, when PAHO moved into other disease control, measles, rubella, and so on, that was the backbone for that. So I think that was a very good thing that really, you know, we started then the weekly feedback reports of polio, you know, weekly negative reporting, and I think that made the difference.
It was a remarkable thing, the reporting, to get all that underway. And I think initially we had thought with the polio eradication that this would be, in a way, comparatively easy because we thought at that time that any child with flaccid paralysis was a polio case. And it wasn't until we got into the program a ways that discovered that there was flaccid paralysis which was not connected with the polio and was not a polio case. This made it difficult, and then you had to develop a laboratory system to get confirmation. And I think it's an illustration of getting off on a program, and you've got a plan. And here it took this was a considerable addition to what we anticipated the need would be to set up a laboratory system, to set up the obtaining of specimens from every case. And I think that was, this was quite a
and also the establishing of the surveillance was kind of complicated in the beginning, because we had, by that time we had a big outbreak of polio in Jamaica. I think over 40 or 60 cases. And Jamaica calculated, they lost millions of dollars in tourism. So when we proposed the establishment of the polio surveillance system, they didn't want to report polio, suspected polio. You see, because that would create problems. So then we suggested, how about flaccid paralysis? Can you report? Said yes, and then created the PFA, acute flaccid paralysis surveillance. Today we laugh about that, but it's incredible that you have to do those kinds of things to get to the right moment, and they were right.
You got to be a bit flexible.
No, but they were right, because acute flaccid paralysis catch many other things.
Yeah.
And polio, the guy looks, no, this is not polio. You see, he will not report.
Yeah.
So in a way, it was good for them and good for us, because we established a good system that, then later on, through the work of the field staff, because the field research was always going on. I think it was Robin Billick that came to this idea of the rate, because he calculated in Brazil the rates, and then said, okay, maybe 1 or 2 cases of AFP per year, per child under 15 and so on. And then we created those indicators. And, in the beginning we had several other indicators, but in the end we came down to 5 indicators, which was manageable for the country and helped the program. Who is reporting? Is it on time?
Yeah.
Do you get samples to the laboratory? The lab is reporting on time. So simple indicators that can be used in the field by everybody and practical.
Yeah.
So it was very important.
I think there was one element that played an important role, which I think you've indicated was first in Cuba and then in Brazil, but the idea of an immunization day to vaccinate all the children under the age of 5 throughout the country on a single day. That was really quite an heroic undertaking. Was it Brazil that really developed this
the genesis of this actually is from SABI. I think that, and sometimes I say, maybe wrongly, that maybe the greatest contribution of SABI was the development of the vaccine, but articulate how the vaccine would work best. And there is no question that he was right. And of course that he tried the first time in Cuba when Fidel was, got in power. There was the first health activity, and demonstrated that was correct. And then some countries in Latin America had done that. Uruguay, Argentina, Venezuela, Mexico, not in a day, but in several days, not in one day. Cuba also did not do in one day, did in several days. Then, in Brazil, the state of Rio Grande do Sul started doing, yearly vaccination, and polio was really down. Clovis Tigre was the director there, and Valdir Arcoverde was the health planner in the state. It happens that a few months later, Valdir Arcoverde becomes Minister of Health. You see, and then he brings all his team from Rio Grande do Sul, and then he puts Rizzi, João Batista Rizzi, in charge of these disease control programs. And then Rizzi came with the idea of let's have a national day. Like a boom, big national day. And then they did the national day in Brazil. And at that time, in a weekend, they vaccinated 20 million people. That time was the biggest vaccination in the world, But it was relatively easy if you went, because there was a real, truly national participation, and everybody participated. It was like a big festival. And actually 3 weeks ago, I was in Brazil in a ceremony commemorating the 4th anniversary of the EPI. And then all the oldies were there, you know, the people that have done those things. Carlyle was there and so on. And, you know, we were commemorating that was done, you know, with the help of the Air Force, helicopters, and everything. And it was very successful. And Sabin could have participated, but unfortunately, it's a sad story because he was invited to come to Brazil. He was married with a Brazilian lady, and very respected in Brazil he was. And Rizzi put him like in his back of his office, like if you are sitting here, Sabin was sitting behind. He gave a very important role to Sabin. And then Sabin started looking at reports from the National Statistical Service, not the health system. You know, that the guys report whatever it is. And then he went to the press and accused the government to lie, that there were thousands of cases in Brazil and they were reporting just very few. You see? And that's when all this brouhaha happened. They went to put him as a persona non grata, but they didn't do because of the wife. You know, and then Sabin left, and he could have been a hero if he had not done that, which he should not have done because the government had already decided to do the campaign. So if they had 10,000 cases or 10 cases, it doesn't matter, you see? And actually he recognized, because, you know, during this period, one day he came to me and said, "Look, Ciro, I think I did a mistake." "Oh, yes, you think?" "Yes, and I would like to apologize to Dr. Rizzi," which was incredible, coming from Sabin. "Can you talk to him?" I said, "I can." And then I called Rizzi. And Rizzi said, "No way, I never want to see this guy again." Because Rizzi was the most honest bureaucrat I have ever seen. And he was so offended that he could not take Sabin anymore. So he didn't apologize, he didn't have the meeting. But anyway, that's history now, and it was, you know, then we had to implement that in the other countries, and we brought several Brazilians, you know, to help in other countries with their experience and so on, and in the end it went on very, very smoothly. We had several problems. We had an outbreak in the northeast of Brazil, which was, you know, a P3 outbreak, which was very worrisome for us. Immediately we suspected about the vaccine, so we sent a team there to look into that. And of course it was low concentration of the vaccine, so immediately we notified manufacturers, and in 6 months they responded and they doubled the concentration. Then we had the cases in Mexico, keep happening again and again and again, and then we found out that they were using still the Mexican vaccine with the old formula and so on, and then the minister at that time, Dr. Kumate, fired the guy, you know, which became a sort of a problem for me, because then they used to say that every time I would go to Mexico, someone would be fired.
Remember Paul Albrecht at NIH tested the vaccine? He called and he said, "It's holy water.
Yeah.
There's nothing in it."
So we had those problems, but eventually, you know, we were on top of it, and we could manage to go through.
I think this was an important point, and I think we saw it in the vaccine program with smallpox. There was a lot of governments using vaccine, which was clearly substandard, and really not paying much attention to it, and making sure that we were getting the results made a big difference. And I think this was a very important consideration. There was a lot of criticism that came up of the days, of the mass vaccination days. They said, you know, this is, you can't repeat this. On the one hand, it was really something that really shouldn't play a role. We should be doing everything as a routine. And yet, as I saw it, it was an opportunity with the vaccination day to get a lot of publicity out, to get a lot of people talking about it at that time. There was a sort of phenomenon that was there. And I know that we heard quite a bit, I heard quite a bit from Geneva about this. They were very unhappy about it. this cannot be repeated. And I remember talking with one of the, I think it was, who was director, the person who was director of the program in Brazil at the time, and I said, you know, this is, I say, you can't get it back every time. These people won't continue coming for days of vaccination days. And I said, but they do, and what's your secret of the success here? He looked at me sort of strangely, and he said, well, we have Carnival every year. Why can't we have vaccination day every year? He was totally baffled. Why can't we? So it was really a very good comment. But it did have an impact, and I think it was a really good impact.
According to the Taylor Commission report, which evaluated if the program was positive or negative to development of health systems, this created a culture of prevention in Latin America. And there is no question, because you know you mobilized all the community, all the main figures, the soccer players, TV stars, everybody.
Presidents.
You know,
yeah,
presidents, everybody, you know, doing things together. Again, collective action at its best. But of course, then we had all the unexpected.
Yeah.
You see, like we had then this sudden outbreak in Dominican Republic and Haiti.
Yeah.
You know, what the hell is this? You know, and then found out that it was a circulating vaccine-derived virus. You see, which was at that time really not very well known, that phenomena. I think it was the first time that was registered and published. And of course that the vaccination with the OPV immediately stopped that. So that was an unexpected thing that happened. And
I think these various illustrations are important because I think many people have heard about the polio eradication or the mass vaccination program, what have you, but they don't realize how many problems there are if we set out with certain goals, certain targets, certain method of working, and making certain assumptions that you continue on. But instead, as you found out, we find problems with the vaccine. We've got to deal with that. We've got problems of finding out with the surveillance. It's not what we thought it would be. And it was a continual work of evaluation in the field, epidemiology, and continuing evaluation in the laboratory, doing research, and constantly looking at the program and how do you make sure that you're getting the results you are, or is there a better way to do it? And
yeah.
you had this one way or another instinctively just brought in over and over again. And it was not just a mass vaccination program and that was it.
No, it was a disease control program that you utilize, and I keep arguing now again and again that there is not this issue of routine vaccination and non-routine vaccination. You have a disease control program that you use as the technology's vaccine. Now, you use this vaccine in the best way you can according to the level of development of the health system in a different country, in each country. If a country can reach everybody, you don't need to have any outreach. Sure. People can come to the clinics and get the services. But if the service don't reach everybody, you need to have these different tactics. Yeah. Outreach, campaigns, week campaign, national day, whatever. And this is all part of routine. This is all part of, all is routine, all you do routinely. You go to the dictionary, it's a routine, what you do again and again and again. And if you do the campaign again and again and again, it's a routine. So now I criticize the people because they have now, they presented in SAGE the committee on RI. I said, RI, are you talking about Rotary International? No, that's routine immunization. You see, so, but we were, you see, part of the success of this was one, that we recruited young, enthusiastic people, you know, like when John Andrus came to work here. Everybody in that same age range, you know, early 30s, late 20s, you know, that went to do something. They went to change the world. They went to do something different. And they went to see the results. So that was a very important thing. Tremendous dedication. And then we had another thing which, in my opinion, is what can make the difference in the technical cooperation of organizations such as PAHO. You have to keep the eye on the ball. So the people that we had in each country, and I had the agreement of all the directors, they had to work 100% only with the immunization program. because the practice in PAHO or WHO is that you put staff in the country and they work for 10 different things, meaning that they are not working in anything. So then in our program, everybody was full-time with the ball, the eye on the ball. And of course, in emergencies, we said in any emergency, everybody has to work in the emergency. So
Like
if there is
cholera.
an earthquake,
Yeah.
everybody stops and work. If there is a cholera outbreak, you go and work, So you work in the emergencies. But when the emergency is gone, you keep the eye on the ball. And then WRs, many hated me because of that, because they could not use my staff, you see? And all the directors were very good because they were behind me. They supported that. If a director would knew that, this problem would not have happened. So that's something that is a lesson for international organizations that are providing technical cooperation. You have to look what's the program, and then you do that. You don't disperse your people doing different things, you see?
In 1985, you set the goal of polio elimination for the Americas by 1990. And then you followed along here with measles elimination. How did that come about?
Yeah, let me tell you, finish what I was trying to say about the staff. So one is that they had to work 100% there. And second, they had to have an office in the Ministry of Health, not in PAHO office. You see, because all the PAHO staff is in the PAHO office. The API people had to be in the Ministry of Health as
Very
part
good.
of the team. And they should go to PAHO for meetings whenever they needed, but they had to be in the ministry. So that made the difference. And is an example for future programs. Then, of course, polio is eradicated.
And I think we should add that the directors of the programs, whether they're in Geneva or regional office or wherever, spend a fair amount of time in the field really keeping in touch with what's going on.
Absolutely. Yeah, that's
Not
very key.
sitting behind the
Yeah,
desk,
absolutely. You have to be out there.
which you did a
Yeah,
lot
no,
of, which I did a lot of.
I traveled almost half of my time,
Exactly.
between 40 and 50%.
Right.
So you are always out there, which is not good sometimes for the family, but the family was very supportive. So then we finished polio, and now what? So we had during the polio eradication, an experience with Cuba that was going to ask for our advice on the issue of measles and rubella. So we went there, Alan Heeman from CDC went with me, and then we analyzed the situation, and they were due to a major rubella outbreak. And then we proposed to make a big campaign for rubella and measles. We had the experience of West Africa when they vaccinated all children under 5 with measles, and transmission was stopped. So that was a good, piece of information that we had. We looked at the epidemiology of measles in the Americas and in Cuba, and the age group has already shifted. So not more than 90% of the cases were in under 15. So we proposed to make a campaign, with measles, with MMR to all children under 15 in Cuba, and to give rubella vaccine to women up to 25 years of age. And they did that, and they stopped transmission of measles. So we had that experience. Then we had a meeting of the directing council, or the executive committee actually, and the president of the committee was a Minister of Health of Bahamas called Norman Gay. And I was sitting by him during this presentation, and he told me, Ciro, we don't have polio anymore here in the Caribbean. What should we do? I said, why don't you eradicate measles? He said, good idea. What shall we do? And then we kept the conversation, and then he went back and talked to his peers, and then they come back and said, yeah, we want to do it.
That's the
So,
Caribbean country.
The Caribbean country. So we went there, and then we looked at the epidemiology of measles, the cost of measles, the rubella situation, and then, we did the campaign on measles there, and the whole thing was gone. And then we kept being pressured by the other governments to launch a measles eradication. And we start resisting because we thought that putting that immediately together would require much more resources and could kind of jeopardize the end of the polio because we were towards the end. We said, let's hold back, you know, until a time which was impossible. Then the Minister of Health of Central America said, we are going to do it. Okay, then the horse went out and then we had to do it. And I remember that I had also to convince you in a TAG meeting in Cartagena, and then you accept that that would be feasible, and then we launched. Then, you know, we also got the target. The target was 2000, no? And we
Yes.
lost for 2 years. We had 2002 the last cases.
2 years over, where with polio we're only
Yeah.
8 months.
And then, so the last case was in Venezuela in 2002.
Yeah.
And then, of
November.
course, that immediately went into a mode of rubella eradication. Because, you know, when measles disappeared, we found out the amount of rubella was enormous in the region. And many countries were already using the MR vaccine. And then the rubella came as a natural and then was eradicated. The last case was in 2009. So,
Rubella, the last endemic
yeah,
case, yes.
2009.
Yep.
But
So,
here again, it seemed to me that the strategy originally was to vaccinate women up to the age of 40 as well, and thinking that this would
yeah, we started with a stepwise approach. First, the recommendation said, if you want to eradicate rubella congenital syndrome, you vaccinate all the women after a certain age, 35, 40, according to the epidemiology in the country. And that evolved to another question. Okay, you eliminate syndrome, the rubella congenital syndrome, but you are continuing to have transmission among the men. So the women eventually will get a group of women that will be susceptible because the countries are not going to keep up this high coverage. So the solution for the CRS is to eradicate rubella. And to eradicate rubella, you have to vaccinate the men. So then the countries started in the mode of going all the population. The first country was Costa Rica. They did very well. And then we had the proof that the strategy of only women didn't work in Chile and in Brazil.
Yep.
When they vaccinate only the women, they start having outbreaks in the men, going back to the women, until they had to do again the campaigns to include the male. And then rubella was gone.
Well, I think it's another illustration of heading off with one goal in mind, and a strategy, which you had to modify as you learn more. And it was, I think, the difficulty we have with some of the programs is they start out in a direction and continue it, and don't ever reappraise what needs to be done or how we modify it or do we get better vaccine. It's sort of set in concrete, and you don't have the input of reporting. And are you really covering everybody? What do you do about cases that are occurring? Are they in one group, let's say Muslims in India, for example, and with all Hindu vaccinators, and you find out we got a problem, we have to change it. But this is what I think is really one of the problems that we've had, that people have not been quite so adaptable and thinking through all the time, where are we and what do we need to do to finish
Yeah,
off the job.
it's because many times, you know,
We have to change.
The EPI program and followed by the polio and measles and then rubella elimination efforts have been dramatic indeed and have made a tremendous impact. And I know that at Sabin Foundation, Sabin Institute, now that you have moved your headquarters over there, I know you're exploring some very interesting areas, and maybe you could give us a word or two on what what you're about and your agenda at the Sabin Institute.
Yes, I retired from PAHO in September 2002. And the Sabin Vaccine Institute was looking for a president. So they approached me if I wanted to be the president of the institute. I said, look, I had my whole life here working management and so on, and now I don't want to do that anymore. So I cannot be the president, but I could help you with some programs, because at that time the Sabin Institute was kind of very parochial. They only ran 2 activities. One was a meeting in Cold Springs Harbor Laboratory, which was very important meetings that they had, assembling 30 or 34 people that fits there in that place to discuss a topic in vaccines, and they published a document, which was very useful. And then they had also a consortium for cancer vaccines, and they had meetings also every year. So with my joining the institute, we start doing what I call international programs, and then we made the institute become more international. And what I did was to try to bring the experience of PAHO to other regions. So I started first with, the idea that we need to have better information for the countries to be able to introduce vaccines. So we got grants to work, to do meta-analysis of the situation of burden of pneumococcal disease, meningococcal disease, rotavirus, HPV in the Americas particularly. Then we did that in other parts of the world. And then we assembled governments to present that information, and we published in peer-reviewed journals. So that motivated the countries to accelerate the introduction of those vaccines. After we had the rotavirus meeting, several countries started introducing the vaccine. You see, so that is a very important thing that we start doing. PAHO now is doing with John an important program which is similar to that, and it's actually like that, which is the PROVAC, that we are collaborating on. So that was one area. The other area was that, the Gates Foundation was financing these meetings in Cold Spring Harbor. And they thought that this was already, old stuff. So they approached me and said, look, we are not more interested in financing that. And in your opinion, what's the issue now in vaccination in the world? And then I mentioned to them that, in my opinion, the issue today is the financing of the programs. Because the Gavi was very important, the formation of Gavi, but there is no indication yet of when the Gavi support stops, if the countries are able to continue with these very expensive vaccines. So that's something that worries me a lot until now. And I told them that in PAHO we had done something with ministers of finance, parliaments, that had helped the countries to come to a level that now they finance 99% of the programs. So they said, send us a concept paper about this. So I sent a 4-page concept of what could be done, that we should have, some people that would go around to talk to the Minister of Health, Finance, and Parliament, and so on. And then eventually they asked for a proposal. So, and then we got a $9.5 million, and then we chose 12 countries in Africa and Asia, which were decided in collaboration with WHO, Gavi, and UNICEF, which countries we should start working. And the idea of this program is to bring the experience in the Americas to a higher level. In which respect? Is that what we do, we don't bring money to the country. So in the beginning everybody asked, but why are you here if you don't have any money? So no, we want you to pay. We want your money. We want country ownership. This is the new mantra, country ownership. And then we assemble these guys in the countries that we work. Every 3 to 4 months they had a colloquia, national colloquia, in which representatives of health, finance, and parliament get together, and then the health minister presents the plan, the finance minister see the figures, and the parliament see the figures and see what they have to do in terms of enacting laws. So because our goal is that countries increase their share and enact laws to protect the budget line. We are working now for 5 years, and we have a tremendous success story. You know, several countries have drafted legislation, which are now in the stages of approval in some countries, and there are now more funds coming from the national government to the program, including, you know, creation of national immunization fund with support of public sector. You know, in some countries they are assembling all the mayorships so that the mayors also have to put money in the program. So many innovative things, and everything is innovative in this project. So that's one thing that we do, and I think it's a very important thing because it's bringing all this experience from PAHO. The first colloquium that we had with all countries, which was in Addis Ababa 2 years ago, I brought parliamentarians from Latin America to tell the parliamentarians in Africa how they did it. And we were so successful and so lucky to get 2 parliamentarians, one from Bolivia, which was an Indian guy, which actually is from the opposition party, but dynamic. He is the head of the Health Committee and Social Committee. And the El Salvadoran representative, also head of the Health Committee, was a former guerrilla. So they were very articulate.
It was excellent. I went with them.
You were there.
Yeah, I was there. I saw
So
it. It was amazing.
The
Yeah.
people got fired, you
Yeah.
see, and now they became fantastic parliamentarians. So it's amazing because now they realize that they can legislate. Because until now the parliaments were rubber stamping. And the first time, this is beyond immunization, we are helping the parliaments to legislate. You see? So it's something out of the world. It's something that is unbelievable. So it went beyond my expectation. And then we do some other special projects, such as, you know, I raised over these last 5 years about $16 million, which all of that were to projects together with PAHO. Because the philosophy of the Institute is that we should work, we should not be implementers, we should help others do the job. So if we work in the Americas, we do it PAHO. If it's in Africa, we do it with the regional office. Dr. Sambo came to my office, we had an agreement of which things we do together, in Asia, in Europe. And then we do initiatives with them, like we are doing, we got associated now, I became 3 or 4 years ago, the immunization advisor for IPA, in a very strange way, because when they called me, I said, I'm not a pediatrician. They said, we make you an honorary one. So I became an advisor to IPA on vaccine issues. And then I said, we need to have a committee. I cannot be the advisor. We need to have a committee. So we created a committee, you know, with Lou Cooper and Nick Grange, that was minister in Nigeria, and past president, a lady from the Middle East, a guy from India. We created a committee that I call the TAG for immunization, TAG for IPA. And then I convinced the president, I said, look guys, why IPA could not be for measles and rubella what Rotary did for polio? You see, not in terms of raising money, but in terms of advocacy. And then I got a grant, and then they accepted. We now, the IPA will be a major advocate for measles and rubella. And then I held a meeting in Rome for all the European countries, all the pediatricians of Europe, to discuss measles and rubella. I had a meeting in Nepal with all the Asian pediatricians, and this together with WHO, Regional Office of Europe, and Ciro and UPRO. And now, in November, we're having Accra for Africa, with all the pediatricians and government officials to discuss measles and rubella. So we do this kind of thing for mobilization. We created also, which now is already sunset, a pneumococcal awareness council of experts, in that I put together about 14 experts in pneumococcus in the world, and we had meetings, several meetings in different regions on pneumococcal disease. We have now created, together with Matu Santoshan from Johns Hopkins, a council for rotavirus, which we are the co-chairs, and we also promote every 2 years a big rotavirus meeting, and do advocacy in the countries. And we are, supporting here PAHO with surveillance for dengue, surveillance for improving the pertussis surveillance with introduction of new technologies, real-time PCR, and so on and so forth. which we are expanding. So it's a big portfolio of projects that we have in the area of vaccines, which I work more time on that. But we have two very important areas in the same institute, which is one is development of vaccines, which is headed by Peter Otes, and vaccines for diseases of poverty. We have a portfolio of hookworm, schistoleishmania, malaria, and SARS. The most advanced one, most of them are in the in discovery of antigens and so on. But hookworm is already in phase 1 trial in Brazil. And we want to do this together with the countries that are endemic for the disease. So from the outset, we signed an agreement with Brazil, Fiocruz and Butantan, for doing the clinical trials, and we transfer the technology for the vaccine production. So everything will be done in that way. So that's a very important area. And then we run another component of the institute, which we call the Global Network for Neglected Tropical Diseases. And this is a fundraising operation that we raise funds. We raised already over $100 million. And we work together with PAHO in the Americas, Afro, Southeast Asia, and here in the Americas also the Development Bank. And we give this money to this hub, and then this money goes to the people that is doing the work, according to the proposal that they send, is analyzed by PAHO and so on. So that's a very important thing. And in the other area of vaccine, we run a coalition that we call Coalition Against Typhoid, that we have now over 28 institutions together, working together. And it's the first time that the typhoid community gets together and dialogues, and they had never met together. So now we have all these institutions that, we have NIH, Wellcome Trust, WHO, several other institutes, Aga Khan University, IVI, 28 institutions. You can see in our web page. It's a fantastic thing, and they meet very often, and the thing is advancing. So this is basically what the same institute is doing, and I think that we are being a sort of a voice now in global health, and we hope that this will continue, and I'm sure it will.
Well, I mean, when you describe that story of going from 2 meetings a year to what you're doing is incredible. And also, again, confronting unexpected challenges. I know that from the hookworm vaccine, for example, what Peter Hotez has been working on, the first version, they had a setback with the adverse events and the allergic reactions.
Yeah.
But they're nimble. They came in now with another potential alternative that seems to be working, and so it's amazing. And I think that the whole thing about neglected tropical diseases, when you quantify the DALYs, the disability adjusted life years, as the measure of disease burden, it ranks up with TB, malaria. So it's amazing work. Hats off to the Institute.
Thank you.
There's obviously a broad new area out there that really has been nibbled at. And you're bringing them together in a configuration.
Yeah, particularly this program, which I call Sustainable Immunization Financing, because we are honest brokers. You see, we are trying to facilitate. We sit in the back seat. For instance, in the colloquium now that we have in Dakar, we were sitting in the back seats. In the front seats were the parliamentarians, the finance guys, the Ministry of Health guys, and we had no lectures. Nobody presented any lecture. The guy from WHO presented the slides, which was the only one, and I could not stop. But all the system was like a Davos meeting, a big number of seats, and the parliamentarians and talking to each other, peer to peer. And we are in the back, just looking at what's happening.
Is this where they showed the posters?
Yeah.
One of the statements that's been made by some is to say, well, you've been able to do some really unique things in the Americas, within PAHO. But this is a different region than some of the other WHO regions. In other words, it has a somewhat different budget structure, somewhat a larger income per capita, if you will. It's been, countries have been working together in the past. It's got a longer history than many of the other regional offices. Can you get anything approximating this in such as the Southeast Asia office or African office? Can you get anything approximating this sort of coherence and dialogue and joining together such as you seen developed in the Americas?
I think you can, but you need to be persistent and you need to be out there. I think the world lost about 15 to 20 years for not bringing this experience in the Americas to the other parts of the world. I recall when we created the ICC here, the Canadians were helping us because they had a Brian Mulroney initiative for the Francophone Africa, and I could convince the head of that program, which was Ed Reagan, which was the head of the Canadian Public Health Association in charge of the immunization initiative, to give some money to the Caribbean, and actually they gave, I think, $2 million. So he attended these meetings. So he had to do the program in Africa. So he brought the same idea. He said, we need to have an ICC, we need to have national plans of action, and everybody blocked, including the people from CDC. No, this cannot be done in Africa. So they dismissed. And the reason was that the Germans want to do something, the French, the English, they want to be divided, to rule. So they didn't want. Then when Gavi came into being, that Torre Godal modeled Gavi on our initiative, then they start creating the ICCs. And it works well, if there is a follow-up. Now our initiative of sustainable financing, it's working well. They sit together, they dialogue, they get enthusiastic. So you can do it. Maybe it take a little bit longer. Today, the African countries, for instance, are paying only 45% of the programs. But you know, can we in 2 or 3 years go to 60%, 70%? I think we can. But we need to be there. If we are not there, we are not doing the job. And again, this is part of the, you know, I have been now in public health for 45 years. You know, there is a great change in the scenery, the global scenery. And for me, some of the changes are that you have many more actors now in the global health. Before WHO was the only ruler. Now it's not that anymore. You have the financial institutions, you have the foundations. The Gates Foundation became the big, you know, orangutan in the room, you know, and became actually the leader of global health in a sense. So this is a tremendous change. But with a major, in my opinion, a major handicap that in my opinion is totally unacceptable, which is the culture of paternalism. All of those organizations are paternalistic. All of them. And unless we change this paternalistic approach, we will not succeed. So my mantra now is country ownership. And that's why this sustainable immunization finance is all about. It's the beginning of country ownership, in that parliaments gets involved. This is our program. You know, that's what we should do. So this, in my opinion, is a challenge that we have. How can we change this? I was, by chance, the co-chair of the Global Vaccine Action Plan, you know, the decade of the vaccines. I was the co-chair. And if you can see there, the first principle of the thing is country ownership. That's the first principle. And you don't find in any page the word donor. There is no donor. Everybody has to be together as partners. There should be partnerships, not donor and recipient. Because the way that these agents come to the countries is, we are giving you things. We are giving you things. And we are having now, even with our program, and I had a big discussion in Dakar after the meeting when we had the partners together. I said, look, we are having countries that sometimes the country has difficulty to buy the vaccine, and instead of you guys saying, let's see if we find the money here, you guys come, don't worry, I give you the money. We have to stop this.
Yeah.
We have to dialogue with the countries in the same level, because nobody's giving anything. They are investing. If the US or Europe or Canada is giving money to a country, they are not giving the money. They are investing the money there, that they will have better health, better development, therefore they will have less pressure for immigration, you see, and the world will be healthier. So they are not giving. Eliminate the word donor. There is no donor. Everybody's partner. And that's my mantra. So that's the biggest change I see in the global health, all these new actors, but still we need more change. And the change that we need is that we have focus now on country ownership.
And one of the problems I think we face is that in many countries the strength of the health ministries is pretty weak, and they're pretty far down the pecking order in terms of importance within government. And it does, one can say this is true in the Americas as well in some areas. But I can see some difficulties of how you keep this going, and as the Sabin Institute, you can cover so much. There's a lot of activity here. Are you thinking of getting some Sabin Institute Junior or other Sabin clones growing so that kind of promote this?
No, we wanted to have, you know, a presence in the countries, but in a way that is also giving the message of country ownership. For instance, my program of sustainable financing took some time to take off because I could not find the right people. Because my principle was to have one person to work in 3 countries, so that we have one person as chaperone for 3 countries. But this person had to be somebody with public health and financial economist kind of background from one of the 3 countries. And that was abroad, so that I went to repatriate the brain. So I have to find those guys. You know, it took some time. I found an economist from Cameroon in the World Bank. Took me 4 meetings to convince him to go back. I said, look, you will live in your house, you will have a good salary in dollars, you will have a life of a king. You see? So the guy accepted, went, and extremely happy.
So he'll be in Cameroon.
He's in Cameroon, but he works in Cameroon, Mali, and another French-speaking, I forgot the 3rd country that he works. You see? I found an economist from Uganda working with DFID. She went back to DFID and now back to Uganda. Now she works with Uganda, Ethiopia, and Kenya. I found a German economist teaching, a Nepalese economist teaching Germany. He went back now, he lives in Nepal and works in Nepal, Cambodia, and Laos. I found an economist from Mongolia, trained in Japan, working in a Beltway NGO here, Bandit, whatever they call. And now she's in Mongolia, working with Mongolia, Vietnam, and Indonesia. You see, so I brought these brains back, and they are happy, and the countries are happy because there is no blonde guy, you know, coming telling them what to do. They are from the area. You see?
Now, what kind of a feedback can you give, or can they give, for each of those areas to a broader audience to explain this is what we've done and this has been our experience and we found this to be quite effective in our area? And how do you communicate?
Through the colloquium, you know, to the peer exchange. We send, within this program, we send people, the finance people from Nepal, for instance, goes to Cambodia. You see? The Cambodian people go to Laos. The Ugandan guys go to Kenya. So you have this peer exchange. You see, that's permanently moving. And then I got another grant now of $5 million to create, and is already created, this association, International Association of Immunization Managers, which will be other fora to help this. And one of the major features of this association will be peer-to-peer. You see, like we did in the Caribbean and Latin America, so that they will be visiting each other and learning from each other, and so that we are now socializing the information.
I think
that's the idea.
What it strikes me is from that socialization you have the spirit of core that develops, but then you have sort of a competition, because when you share information like that, everybody wants to demonstrate they can do it as well. So it's you're taking that experience from Latin America,
Yeah.
and every opportunity
Yeah.
you have, it's great.
I must say, Ciro, it's a fantastic concept, and I had never thought of it. And when I first heard of it, I couldn't believe that you would be doing what you were doing. There's three very disparate parts of government coming together. I thought, this is crazy. But obviously, it's working.
It's working very well.
It's again another bit from Ciro's creative mind. It's just one more beautiful piece that is going to change public health. It's going to change governments. It's going to change
Absolutely.
the health of the public,
Yeah.
period, in a way that is really hard to imagine and maybe not even quantifiable as such. But
And I think that there are, again, you know, the timing is very important. I think that the initiative of Tahoe in pushing for the global immunization day or week was a very important thing, because this now will come to a level that immunization will be very visible in the rest of the world, like in the Americas.
very good.
So that this global immunization week will be a very important thing, you know, so that parliamentarians can see that what I'm doing is really important.
Mhm.
So this will be another thing that will be, you know, injecting additional, you know, power to this movement.
One of the things that I really regret is that we do not have the sort of documentation of what you've done, particularly the EPI, in a way that we could cast it for a major prize with one of the foundations. Because this truly is an achievement well beyond what most people just don't even appreciate, what has gone on and what has come from this and what you've done with it. And so it's something I'm going to continue thinking about, working on, because I think of all the achievements in medicine and all that's been made of the smallpox and how great this really was, I look at what this whole broader structure and your thinking of public health is like another 3 steps beyond where I thought we might go, and you're already doing this. This is absolutely
It's an
fantastic.
evolution, because what we did is simply from the lessons we learned in the past in other programs, starting with smallpox. So all those things is an evolution of the thinking and the, you know, the elaboration of new strategies. So I think that's a natural history of things, and I'm very grateful to have had the opportunity to work with you for many years, and you know, you have been an outstanding mentor to me, and I'm very appreciative of that. And besides that, I want to disclaim anything that was done in that I participate was done because of the people involved. So I think that the people is the most important ingredient on that, and to have the feeling of, again, of ownership, so that everybody is the owner of the, you know, you see even, you know, everybody in the organization, you know, is part of that. When you look around, you know, and you know, the tremendous job that, for instance, the crew that's here does, it's amazing. What they have done, you know, over the years with the public relations people here, you know, in lots of videos and, you know, public announcements and organization of lots of things is part of the whole process. And they feel that that is their success. And that's why a program is successful, when everybody feels that is their program. That's not my program or yours, it's our program.
Well, in a way, this is a characteristic of a catalyst, isn't it? It's sort of as the catalyst sits in there and affects certain things happening. but the catalyst doesn't usually change very much. It moves it and gets it going, but it's a very small component of
Yeah.
a very major reaction.
Yeah.
And this is certainly it. I must say, in recruiting you at the time and seeing how active you were in Brazil, I sort of had the feeling I might be getting 2 for 1 or 3 for 1, recruiting one and getting the value of 2 for 3, but I hadn't quite expected to see what we did get. It's really been quite amazing. But there's somebody here that we really need to take cognizance of, and that's Susanna and your 4 kids who you've certainly traveled the world, and they've certainly been a patient family. Tell us something about the family.
They have been terrific, and I know that it has not been very easy because, both the wife and the kids, if the father is not home every day, it's different. So it's a different kind of family, and I'm sure that you had the same experience. But I think they adapted very well. In any opportunity that I had, the family was with me. I had as a rule that every Caribbean meeting, the family would go together and we'd stay another 2 or 3 days to enjoy the island, and that's something that they still remember. You see, they stopped going after they were already bigger, but they enjoyed that, and any time that they could go with me, they would go. But they were extremely supportive, and I could not have done anything without that. So that's Suzanne and the kids were terrific, and I'm also very happy that happened and very thankful to them.
Well, you have a very understanding wife indeed, and one who's talented besides as an artist.
And I have three of her paintings in my office, and everybody comes and, wow, who did that? I said, that's my wife.
I've got one over there. But Susanna's been spectacular, and you mentioned the kids they have as well. But the younger generation, what advice would you give to a young medical student or somebody in school that's thinking about a career in public health?
One, I think that you have to be really convinced of what you want to do. I think that's the important thing, because, nowadays, the children, they graduate and then they really don't know if what they graduate is what they want to do. You see, so it's, the world is so different, with all the economic crisis, people don't see future and this and that. So I think you need to be really clear that that's what you want to do. And then I think every morning you have to wake up and be good at it, and get enthusiasm. This morning I was talking with the new staff, saying that, how is your first 2 months here? Do you feel okay? Are you doing all right? I said, fine. I said, look, if you wake in the morning and you don't feel the urge to go to the office, you are not in the right place. You have to wake up in the morning and say, wow, I'm going to my work. And that has been my philosophy. I have to be happy, because at the end of the day, if you are not happy, you cannot do your job, and you will not make other people happy. So,
when you were saying that, I had a memory as you were speaking about, and it was, I think, in 1989, and it was in Quito. And we were coming back late to the hotel after meetings all day, and I remember there was a full moon, and you looked at the moon and you pointed at it, and you said, John, if we want, we could go there. And you bring that attitude, you bring that spirit and that commitment. As you say, as you wake up every day, let's go there. It's clear, and that's why you're such a great mentor.
Thank you, John.
Well, I must say, this has probably been the most interesting few hours that I've spent in a very long time, meeting with 2 old friends who have shared sort of a lot of the ups and downs and challenges and that we have, and have at this point in time can at least look back and see how some of the little acorns that were planted have not grown into just seedlings, but they're giant oaks. And sometimes it's the things that you have planted really don't have your name on it, but they are part of the whole process of growing and what have you. So you've made a contribution, but you have to live with the, I think, the happiest moments of seeing what has happened, not what everybody identifies actually, what all that went on. And I think what is, we can appreciate particularly, I think, better than most, what you have done. And even then, I'm sure we're only appreciating a part of it, because you have planted a lot of little acorns, and they're maturing like nobody's business. And I don't think there are that many people who can identify some of these ideas with how all this got started, and how they got started, and how a whole huge project got started. So I think you have to feel good inside, not expected to get the applause, and if you do, it's probably wrong, because you have appreciation yourself that there are just an awful lot of people who contributed bits and pieces and helped build that edifice, whatever it is. But Ciro, I mean, thank you for being you. And John, I must say, what a great pair. And John and Ciro and I have looked at questions and what to bring out. I'm sure we've so many other things that could be brought out yet, but I think this has been a wonderful few hours. So I appreciate the opportunity to be here and sort of minimally preside over a wonderful afternoon. Thank you.
Thank you.
Thanks, DA. And I just end by saying, on behalf of the Pan American Health Organization, what a delight this has been, and how much of an honor and just an amazing opportunity to celebrate Ciro's lifelong contribution to the health of the people of the world, and generally the people that are most needful of that kind of help, the poorest of the poor, the most marginalized, has always been an approach that you have taken. But thanks again. It's been an incredible time to share these personal experiences and these stories, to hear the stories, and to better appreciate what a contribution you have made, Ciro. So thanks again for being a mentor and being a colleague and being a brother. Thank you.
Thank you. Thank you. So now we need the introduction.
The introduction. Yeah. Okay, let's.
Will it never end?
Wait.
And just a final word of thanks to you, DA. Your contribution as the chairperson of our technical advisory group over the years that Ciro described, your leadership has been outstanding, and I can't express how much we appreciate your leadership and contribution to the work of the technical cooperation that the Pan American Health Organization provides to countries. And thanks for taking the lead on this. It was your idea, and it was really, I think, a great opportunity to learn more about Ciro's career, and thank you for leading the discussion.
I am Dr. D.A. Henderson. I'm Emeritus Dean of Johns Hopkins School of Hygiene, Public Health, and former professor. During an 11-year period, I was director of the global program for smallpox eradication. We ran out of cases, and I ran out of a job. And later, I served as chairman of the technical advisory group for the program on immunization in the Americas. And as such, I had a long-term but very close view of a lot of developments in public health. In fact, some 58 years now since I entered the field of public health. I'm joined here today with Dr. John Andrus, who's Deputy Director of Pan American Health Organization, a colleague for many years, and an old friend and someone who has had the privilege, as I have, of working with Dr. Ciro de Quadros. Based on my long experience in the field of public health, I view the achievements for which Dr. de Quadros has been the author, instigator, catalyst, as being among the greatest achievements in public health. And I say that advisedly. We've had many who talk about the eradication of smallpox having been one of the great achievements of the 20th century. I think it pales in comparison to what Ciro has done in being a catalyst in the development of the global program on immunization, in beginning initiatives which are worldwide, in bringing together those in government and health, in medicine, in the public sector, in programs of great importance to the world. It's a talent that he has, which I've looked at and followed with awe. I think it's really remarkable. So we're privileged to have with us today Ciro, who has participated in so many events which have been described in formal papers very well. But in fact, as we all know, that the difference between what's in a paper and the events which are around that, surrounded in terms of instigating it, of events that make it what it is, are very different. And to have Ciro with us to talk candidly about how some of these great events in history came about, of some of the adventures we had, is really a privilege. And John and I have talked about an agenda and how best to bring this. John has a considerable experience with PAHO as a major player and worked in PAHO, I think, now in more than a decade. And between the two of us, I think we have seen up close Ciro's achievements. And so for both of us, this is a special treat to have Ciro with us to candidly appraise the work of what amounts to close to half a century.